mené cette étude
Et pour ceux qui ne savent pas,
Kinshasa, c'est la plus grande métropole.
Pour ceux qui ne savent pas,
Kinshasa, c'est la plus grande métropole
du Congo.
Avec une particularité très importante, c'est sa densité.
Très forte densité estimée à 940
Sa très forte densité
habitants
estimée à
par kilomètre
940 habitants par kilomètre.
Comment avons-nous procédé?
Nous avons mené une étude cas témoin. Nous avons mené
sur un
une
échantillon
étude témoin
minimal
sur un
calculé
échantillon
à 500
minimal
cas
calculé à 500
250
250 cas.
Et nous avons réalisé pour ce faire un échantillonnage
Et nous avons réalisé pour ce faire un échantillonnage
Alors, je vais vous donner une idée comment on a
Alors,
fait.
je vais vous donner
Nous avons
une
d'abord
idée comment on a
classé
fait.
les 14 zones en épidémie.
Nous avons d'abord
selon la
classé les 14
configuration
zones
de
en
l'antépidème,
épidémie selon la configuration de
Kinshasa,
l'antépidème,
à savoir
du
Kin centre,
du Kinshasa,
Kin
à
est
savoir
et Kin
Kin
ouest.
centre,
à partir desquels 8 zones de
à
santé
partir desquels
ayant constitué
8 zones de
l'échantillon de
santé
cette
ayant
épidémie
constitué
ont été
l'échantillon de cette
sélectionnés.
épidémie.
Et cette
ont été
sélection aléatoire
sélectionnés.
simple a été
Et
réalisée
cette sélection aléatoire
proportionnellement
simple a été
au
réalisée
poids de chaque antenne.
proportionnellement au poids de chaque antenne.
Alors, pour déterminer la part
Alors,
de
pour
l'échantillon
déterminer
dans chaque
la
antenne,
part de l'échantillon
nous avons
dans chaque
réalisé
antenne,
une allocation
nous avons
proportionnelle des
réalisé
unités
une allocation
statistiques dans le 8 zones
proportionnelle
de
des
santé
unités
sélectionnées.
statistiques dans le 8 zones
Et
de
là, nous
santé
avons tenu compte du
sélectionnées.
poids de chaque zone de
Et là, nous
santé en
avons tenu
fonction
compte du poids
du
de chaque
nombre
zone
de
de
cas
santé en fonction du
rapportés
nombre
par
de
la zone
cas
en
rapportés
2022.
par la zone.
Notre critère
en
de jugement
2022.
principal était
Notre
la
critère
survenue de la
principal
rougeole.
était la survenue de la
Et
rougeole.
qu'avons-nous considéré comme cas?
Et qu'avons-nous considéré
Tous
comme
les cas confirmés à
tous les cas
l'Institut national
confirmés
de recherche
à l'Institut
biologique, donc le
national de
laboratoire
recherche
national,
biologique, donc le laboratoire
et ceux
national.
dont confirmés par
Et
lien
ceux dont,
épidémiologique ont
confirmés
été
par lien
considérés comme
épidémiologique
cas
ont été
également
considérés comme
entre
cas
janvier
également
et
entre
décembre
janvier
2022.
et décembre
Et comme
2022.
témoin, nous avons considéré
Et comme témoin, nous avons
tous les
considéré
voisins proches du cas
tous les voisins
non
proches
atteints de la
du cas
maladie. Et
non
cette sélection de
atteints de la
témoins a
maladie.
été
Et
faite
cette sélection
de
de témoins a
manière
été faite
aléatoire.
de manière aléatoire.
Comme modèle d'analyse,
Comme
nous avons
modèle
réalisé une
d'analyse-
régression logistique qui a été produite à l'aide du logiciel Stata version 17. Et tout d'abord, nous avons produit des rapports de
Cote brute avec les intervalles de confiance à 95% et toutes les variables ayant une valeur de P inférieure ou égale à 0,20 ont été retenues comme variables candidates pour la régression multivariée. Et au finish, les variables après le modèle final ayant une valeur de P inférieure ou égale à 0,05 étaient considérées comme seuil de significativité. Alors, ces tableaux nous montrent un aperçu de la répartition des enfants, des caractéristiques sociodémographiques. C'est n'est qu'une partie, bien sûr. Nous constatons ici que la répartition de caractéristiques était presque homogène dans les deux groupes, excepté pour certaines variables, notamment les statistiques vaccinales, où on trouve que la moitié des cas n'étaient pas vaccinés, comparé aux témoins. Et cette différence était très significative dans notre échantillon. Qu'avons-nous trouvé après analyse multivariée? Évidemment, après ajustement mutuel des variables, évidemment, un effet protecteur. C'est le cas, par exemple, notamment, ce qui a attiré notre attention, c'est les niveaux d'instruction de mère. Lorsqu'on constate que la susceptibilité des enfants de mère ayant un minimum d'instruction, ce que nous appelons au pays le niveau primaire, avait 4 fois moins de risque de développer la rougeole comparé aux enfants de mères analphabètes. Et lorsqu'on regarde également le niveau socio-économique des ménages, on constate que la susceptibilité des enfants issus des classes sociales à indice de richesse très aisé était 4 fois moins susceptible de développer la rougeole comparé aux enfants issus des classes sociales à indice de richesse faible. Mais également, de l'autre côté, on a trouvé que les enfants non vaccinés avaient 3 fois plus de risques de contracter la rougeole comparé aux enfants non vaccinés. Mais également, la promiscuité très élevée a montré une association très significative dans ce modèle de régression logistique. Alors, comme discussion, nous trouvons que l'analphabétisme serait à l'origine de grands problèmes posés par la rougeole en République démocratique du Congo. D'ailleurs, beaucoup d'études réalisées, que ce soit au pays ou en Afrique, ont mis en relief la corrélation qui est entre les niveaux d'instruction de femmes et la non-utilisation des ressources des services de santé. Et plus le niveau d'instruction est bas, faible était la fréquentation des services de santé. Et on a montré également que l'éducation administrative La couverture vaccinale en République démocratique du Congo, plus particulièrement en Kinshasa, concernant les VAR, est restée stagnante les 5 dernières années. Tenez par exemple, en 2022, la couverture administrative de VAR était à 85%, alors qu'elle n'était que de 65% selon les enquêtes indépendantes. Et donc on note un écart de 20 points dans les 5 dernières années entre les couvertures administratives et les enquêtes indépendantes. Et donc vous comprenez que devant cette situation, cette faible couverture vaccinale entraîne une accumulation de susceptibles constituant un groupe fragile, une poche qui entretienne l'épidémie à Kinshasa. Et bien évidemment, l'environnement socio-économique a un impact considérable sur l'état sanitaire d'une communauté. Et donc, plus les conditions de l'habitat est moins bonnes, cela expose l'enfant au risque de morbimortalité. Telle est la situation de Kinshasa. Que pouvons-nous retenir de cette étude? Nous pouvons retenir qu'au-delà de ces aspects cliniques, thérapeutiques ou diagnostiques, la rougeole est liée à des aspects sociaux, culturels et économiques qui devraient être absolument intégrés dans les stratégies d'élimination. D'où la nécessité d'améliorer la couverture vaccinale, l'éducation de la mère et en relevant le niveau socio-économique de la population. Et ça, à travers des intensifications des activités de sensibilisation de la communauté sur les risques. Et comme recommandation aux autorités politico-administratives, à travers cette étude, nous recommandons de mettre en place un programme éducatif de récupération de mères analphabètes et relever les niveaux socio-économiques de la population de Kinshasa, mais renforcer les activités de vaccination de routine, mais aussi surtout en améliorant la qualité du PEF de routine et les activités de vaccination supplémentaires. Et vulgariser le nouveau calendrier vaccinal contre la rougeole qui a été mis en place cette année, qui suggère un rappel de vaccins à 15 mois. Et à la communauté de suivre correctement le calendrier vaccinal et surtout limiter au minimum le contact avec les enfants avec éruption cutanée, surtout en période épidémique. Mesdames et messieurs, chers conférenciers, chers membres du jury et chers évaluateurs, à travers ces mots, nous vous disons merci.
Monsieur Michel Louemboué et elle s'intitule Investigation approfondie des cas de tétanos materno-néonatal dans la zone de santé de Kongolo de janvier à décembre 2022. Michel.
Merci de la parole accordée, chers invités, chers évaluateurs. Nous allons vous présenter ici les résultats obtenus de l'investigation approfondie sur les cas des tétanos néonatal dans la zone de santé de Kongolo de janvier à décembre 2022. Je me nomme Michel Louemboué, en provenance de la République démocratique du Congo. Voilà, durant nos échanges, nous allons devoir parcourir les différents points que vous voyez devant vous. Alors ici, nous allons rappeler qu'au niveau mondial, la mortalité néonatale constitue encore un grand problème de santé publique. Mais nous allons rappeler que le tétanos néonatal, c'est l'une des principales causes de cette mortalité. Alors dans un rapport de l'OMS, publié en 2015, il a été signalé 34 000 décès liés au tétanos néonatal dans le monde. Et pour ce qui est de la République démocratique du Congo, il fait partie des pays qui ont éliminé le tétanos néonatal en 2020. Mais malgré cela, il y a encore des cas qui sont notifiés dans plusieurs contrées y compris dans la zone de santé où nous avons travaillé. Et cette notification arrive à dépasser le seuil d'élimination fixé à inférieur à 1 cas pour 1000 naissances vivantes. Et donc, nous avons eu à faire des analyses des données des routines, ce qui nous a poussé à réaliser cette étude dans le but de décrire les caractéristiques des cas de tétanos néonatal, mais aussi des mères de ces enfants qui ont contracté le tétanos néonatal. Voilà. Un autre cadre d'étude, c'est la zone de santé des Congolo, qui est située dans la province du Tanganyika, en République démocratique du Congo. Nous avons mis la RDC au-dessus, à votre gauche, où nous avons mis en rouge la province du Tanganyika, et on a mis une flèche rouge pour indiquer la zone de santé des Congolo, qui est pratiquement au nord-ouest de notre province. Mais il faut dire que la province partage des limites ou des frontières avec la Tanzanie ainsi que la Zambie. Voilà, nous avons mené cette investigation dans un design descriptif portant sur une collecte qui a été réalisée de manière transversale des données secondaires de tétanos néonatal. Alors, l'échantillonnage était exhaustif des 8 cas de tétanos suspects, plutôt de tétanos néonatal, et de manière secondaire, nous avons réalisé également une enquête ménage dans le souci d'atteindre les femmes en âge de procréer autour de chaque cas, mais également les enfants allant de 0 à 23 mois. Et donc nous avons eu à faire un questionnaire électronique sur l'outil CoboCollect qui nous a permis de collecter les données sociodémographiques et cliniques. Et les analyses statistiques descriptives, nous les avons réalisées avec le logiciel SPSS version 25. Alors, de nos résultats, nous retenons d'abord qu'au vu de la définition des cas que nous avons dans notre guide de surveillance intégrée des maladies et ripostes au niveau pays, la confirmation des cas de rougeole n'a pas besoin des examens des laboratoires selon nos directives. Donc on se base sur la définition des cas, ce qui nous a permis en fait de confirmer les 8 cas de tétanos néonatal qui ont été enregistrés, parmi lesquels il y a eu 5 décès, avec une létalité avoisinant 62,5%. Le sexe ratio homme-femme, c'était de 7 sur 1. L'âge médian de 4 jours, avec une plage allant de 2 à 7. Et donc, les services de consultation prénatale, selon les constats, ne sont pas suffisamment utilisés. Donc, 5 femmes sur 8 seulement ont pu utiliser le service, et ça donne 62% parmi les femmes dont les nouveau-nés ont contracté la rougeole. Et pour ce qui est des accouchements, qui ont donné les 8 cas de tétanos néonatal, 7 de ces accouchements se sont réalisés dans la communauté, disons à domicile, en dehors des structures sanitaires, et d'ailleurs dans des conditions non hygiéniques. Et à cela, on a pu constater que la section du cordon ombilical s'est faite à l'aide de matériel qui n'est pas stérile, et à l'exemple de lames de rasoir, à environ 75% des cas enregistrés. Voilà. Ici, nous avons un graphique où nous avons 2 axes désordonnés. À votre gauche, vous avez les nombres des cas de tétanos néonatal, et à l'ordonnée, à votre droite, vous avez la létalité. Et en abscisse, nous avons les aires de santé de provenance des cas. Vous allez constater que dans cette zone de santé, il n'y a que 4 zones de santé qui ont notifié les cas. Et je signale ici que toutes ces aires de santé sont des aires de santé urbaines. Et c'est beaucoup plus l'aire de santé de Kangoyi qui a enregistré un nombre élevé de cas. Sur les 8 cas, cette aire de santé a enregistré à elle seule 4 cas, ce qui constitue 50% de l'ensemble. Voilà. Ici, c'est un graphique qui nous montre les résultats qu'on a eu de l'enquête ménage qu'on a pu réaliser autour de chaque cas de tétanos néonatal. Et cette enquête a visé les femmes en âge de procréer. Et nous avons également 2 axes ordonnés. L'ordonnée à votre gauche vous montre le nombre de femmes enquêtées et celles qui ont été vaccinées parmi les femmes en âge de procréer. Et l'ordonnée à droite vous montre le taux de couverture vaccinale en TD. TD, c'est l'anatoxine tétanique ainsi que l'anatoxine diphtérique, parce que chez nous, on utilise un vaccin qui est bivalent. Et donc, nous constatons ici que le nombre de femmes, c'est en couleur rose, le nombre de femmes qui ont pu bénéficier d'au moins 3 doses de ce vaccin, ça constitue une proportion de 28,63%, ce qui est trop faible. Alors que nous voulons bien vacciner suffisamment de femmes pour que nous puissions avoir des mères qui peuvent développer des anticorps pouvant protéger dans les futurs leurs enfants. Voilà. En guise de discussion, nous avons repris ici nos principaux résultats, dont nous n'allons pas peut-être revenir parce qu'on les a déjà détaillés. Et nous avons eu à essayer de discuter sur les caractéristiques cliniques qu'on a trouvées ici. Ainsi, il y a quand même des résultats qui ne sont pas similaires qu'on a pu parcourir dans la documentation. À l'exemple de normes de surveillance des maladies évitables par la vaccination de l'OMS, où dans ce document, il est dit que la létalité varie entre 80 à 100%, mais dans notre étude, on a trouvé que c'était autour de 62%. Au Mali, il y a une étude qui a été menée en 2019, où on a trouvé que la létalité avoisinait 30,8%, et pour ce qui est des accouchements à domicile, c'était une proportion attribuable à 23% d'accouchements. Et au Niger également, il y a eu une étude où les accouchements à domicile ont eu la part de 100%, ainsi que la section du cordon avec le matériel non stérile à 93%. Mais aussi, il y a une étude réalisée au Maroc qui date de 2005 où c'était à 56%. Mais on a eu aussi quelques résultats qui étaient proches ou similaires à ceux que nous avons eus. C'est comme l'étude réalisée au Maroc où on a trouvé 62% de létalité, mais aussi en Centrafrique, c'était en 2020, vous avez une étude où on a trouvé la létalité à 54% et les accouchements à domicile autour de 53%. Voilà, ici nous allons dire que cet exercice d'investigation nous a permis de confirmer l'épidémie des rougeoles dans la zone de santé de Congolo. Ainsi, nos résultats montrent d'abord une faible utilisation des services de consultation prénatale par les femmes enceintes, mais aussi un nombre élevé d'accouchements à domicile, ce qui n'est pas normal, alors qu'il y a des structures sanitaires. Nous avons également la section du cordon par des matériels souillés, ce qui expose les enfants qui viennent de naître, et aussi la couverture vaccinale antitétanique chez les femmes en âge de procréer qui est trop simple. À l'unanimité, nous devons reconnaître que la vaccination et le respect des mesures d'asepsie restent un moyen efficace pour lutter contre les tétanos néonatales. On ne s'est pas arrêté là-bas, nous avons dû amener des actions. Premièrement, on a fait une préparation d'un plan de riposte dont les actions requises étaient d'abord de réaliser une vaccination autour de chaque cas, c'est-à-dire les mères qui ont bénéficié de l'enquête ménage autour de cas qui étaient insuffisamment vaccinés ou qui n'étaient pas vaccinés, devaient soit compléter, soit être vaccinés. Et également, on a eu à faire les briefings. Ça, ce sont les prestataires qui ont bénéficié des différents briefings. Vous allez voir qu'on a briefé sur la surveillance et le suivi pour une détection précoce des cas, et aussi sur l'hygiène et soins du cordon ombilical, mais également sur les soins prénatals de qualité. Nous avons également mené un plaidoyer auprès des autorités pour avoir une décision sur la gestion des accoucheurs traditionnels. Et pour chuter, on a eu à avoir des images de terrain où nous avons, sur les 3 enfants qui ont survécu, on a quand même retrouvé 2, parce que le 3e est décédé d'une autre cause. Mais les 2 enfants que vous voyez là-bas sont des enfants qui ont survécu au tétanos néonatal. Et là également, c'est la mère dont l'enfant est décédé d'une autre cause. Nous avons également la photo de l'équipe de l'aire de santé la plus touchée, où nous avons été accompagnés pour préparer un plan de riposte. Nous ne pouvons pas terminer sans remercier les différentes organisations qui nous ont accompagnés, dont l'École de santé publique et la coordination de l'AFENET RDC, ainsi que l'OMS sous bureau Katanga. Chers invités, chers évaluateurs, merci pour votre attention.
Ok, la prochaine présentation sera faite par M. Bakary Oularé et le titre est Facteurs associés à la flambée de coqueluche dans le district de Kokolu, sous-préfecture de l'Insan en Guinée. Et c'est une étude rétrospective.
Merci, monsieur le modérateur, distingués membres du jury. Je vais vous présenter le résultat de mon travail portant sur les facteurs associés à la flambée de Coculus dans le district sanitaire, dans le district de Kokolo, sous préfecture de l'Insansar, en préfecture de l'Eloma en janvier 2023. Je suis Oulari Bakari, je suis médecin et je travaille à la direction préfectorale de la santé de l'Eloma. Notre plan de présentation sera le suivant. En effet, la Coculus est une maladie respiratoire très contagieuse due aux bactéries gram-négatives appelées Bordetella pertussis. Les enfants et les adolescents non immunisés sont les cibles de cette infection et la transmission se fait à travers les gouttelettes de sécrétion d'une personne malade vers une personne infectée. Et la période d'incubation habituelle est de 7 à 10 jours, mais peut varier de 5 à 21 jours. Et la manifestation clinique principale, elle est tout quinteuse, sans fièvre dans la majorité des cas. Quelques complications sont possibles, notamment les pneumonies, les affections neurologiques, les défaillances respiratoires ou multiviscérales. Le diagnostic repose sur la PCR ou le dosage sérologique, sur les sécrétions nasopharyngées. Le traitement est basé sur l'antibiothérapie et c'est une maladie évitable par la vaccination. En 2014, l'OMS estime environ 24 millions de cas de Coculus chez les enfants de moins de 5 ans et 160 700 décès et la majorité des cas ont été notifiés dans les pays à faible revenu. De janvier au 15 septembre 2022, 147 cas ont été notifiés en Afrique du Sud. En septembre 2019, 61 cas ont été notifiés dans la préfecture de Zérékoré, le sud du pays. Et la préfecture de l'Eloma n'avait jamais notifié de cas dans le passé. À la date du 31 janvier 2022, la direction préfectorale de la santé de l'Eloma a été alertée par l'agent PF du centre de santé améro de l'Insansaran la présence des cas de toux dans le village de Djaouéa, district de Kokolo. Une investigation préliminaire menée à la date du 1er janvier a permis d'enregistrer 16 cas. Une réunion d'urgence a été organisée à la direction préfectorale de la santé de l'Eloma, à l'issue de laquelle le centre d'opération d'urgence de santé publique a été activé en mode alerte. L'équipe préfectorale d'alerte et de riposte a été déployée sur le terrain du 3 au 10 janvier pour approfondir les investigations. Quelques hypothèses ont été formulées. La Coculus est associée à la non-vaccination des enfants. La Coculus est associée au contact avec des enfants malades et la Coculus est associée à la promiscuité. L'objectif de notre investigation était de déterminer l'ampleur de la Coculus et identifier les facteurs associés, spécifiquement confirmer l'épidémie, caractériser les cas en temps, lieu et personne, évaluer la couverture vaccinale et identifier les facteurs de risque. Pour atteindre ces objectifs, nous avons mené une étude de cohorte rétrospective couvrant la période du 20 novembre 2022 au 30 janvier 2023 dans le district de Kokolo intéressant les enfants de moins de 1 an à 17 ans. Les définitions opérationnelles des cas ont été tirées du guide CIMR que nous avons contractualisé. D'autres définitions également ont été également défaites en rapport avec les facteurs associés et surtout les malades et les exposés. Pour l'approche méthodologique, nous avons fait une recherche active dans les formations sanitaires où nous avons consulté les registres de consultation, mais aussi dans la communauté au sein des ménages. Une fiche de notification et les fiches de recherche active ont été utilisées pour collecter les données, les variables cliniques, démographiques et les facteurs associés. Et également, nous avons mené une évaluation de couverture vaccinale dans la communauté. Les données collectées ont été saisies dans la base DACS2, extraites sur Excel, nettoyées avant d'être analysées avec EpiInfo. Pour la partie descriptive, nous avons calculé les proportions, la médiane, l'étendue et le taux d'attaque. Mais pour la partie analytique, nous avons calculé le risque relatif avec un intervalle de confiance à 95% comparé à la valeur P inférieure à 0,05. Sur le terrain, nous avons prélevé 20 échantillons de coqueluches et que nous avons envoyés au niveau de l'Institut national de santé et de statistique et parmi dans lesquels 10 échantillons ont été envoyés en France pour la PCR. À présent, quels sont les résultats obtenus? La recherche active menée dans la communauté nous a permis d'identifier 83 cas suspects, dont 5 dans les formations sanitaires et 78 dans la communauté, autour desquels 136 contacts ont été identifiés. Des 83 cas identifiés, 10 cas ont été confirmés par le laboratoire et les 73 cas ont été confirmés par lien épidémiologique. Pour ce qui est des signes et symptômes, 100% de nos cas ont présenté de la fièvre, et les vomissements et la fièvre sont venus respectivement de 75% à 60%. Pour les facteurs de risque, 72,29% des enfants vivaient dans la promiscuité, 83,13% des enfants n'étaient pas vaccinés et 96,39% des cas étaient des contacts. La tranche d'âge de 1 à 4 ans était les plus touchées, avec un taux d'attaque de 14,9 pour 100 habitants. Le sexe masculin et le village de Leysere étaient les plus touchés, respectivement de 6,9 et 46 pour un taux d'attaque de 100 pour 100 habitants. L'analyse de notre courbe montre que la source potentielle de notre flambée était intermittente avec une transmission interhumaine. Le cas du 21 novembre 2022 est le cas index, et le plus grand nombre de cas a été notifié du 7 au 20 décembre 2022 et l'épidémie a commencé le 28 novembre 2022. Et le cas du 28 novembre était en contact avec les cas du premier. C'est ce qui décrit la période d'incubation comme décrit dans la littérature. Dans la communauté, sur 58 enfants rencontrés pour le monitorage de couverture, seulement 28 étaient vaccinés, alors que le centre de santé a affiché une couverture vaccinale supérieure à l'objectif du plan pluriannuel complet qui est supérieur ou égal à 90%. Pour l'analyse des facteurs de risque, nous retenons que les enfants non vaccinés avaient 6,4 fois plus à risque de développer la maladie que les enfants vaccinés. Les enfants vivant dans la promiscuité avaient 1,8 fois plus à risque de développer la maladie que les enfants ne vivant pas dans ces conditions. Et les enfants en contact avec un cas symptomatique au cours des 21 jours avaient 5,7 fois plus à risque de développer la coqueluche que les enfants n'aiment pas rentrer en contact. Et toutes ces associations sont statistiquement significatives. Ceci dit que la non-vaccination augmente le risque de la maladie au sein des enfants. Et cela est en rapport avec le résultat de notre étude. Et cette faible couverture vaccinale expose des enfants à d'autres maladies qui sont protégées contre cet antigène qui est le pentavalent. Et vivre en promiscuité, les enfants vivant en promiscuité avaient beaucoup plus de risques de faire la maladie. Et cela pourrait s'expliquer par non seulement la faible connaissance de la communauté sur les moyens de prévention, mais aussi également la pauvreté. Être en contact avec un cas symptomatique augmente le risque également de la maladie. Et cela pourrait s'expliquer par la contagiosité de cette maladie. Un cas de coqueluche peut infecter 15 à 17 personnes de son entourage, surtout si les enfants ne sont pas vaccinés. Nous n'avons pas rencontré de limites majeures, mais quelques difficultés ont été rencontrées sur le terrain. Notamment, l'insuffisance de kits de prise en charge des cas, l'insuffisance de fonds pour mener les investigations et le suivi des contacts, l'accès difficile des zones touchées. En somme, nous retenons que la majorité des cas et des enfants étaient âgés de 1 à 4 ans. La toux, les vomissements et la fièvre constituent les symptômes prédominants et la majorité des enfants ne sont pas vaccinés, c'est ce qui peut les exposer à d'autres maladies. Les villages de Leysere, Sinkuru et Djaouya étaient l'épicentre. Et être contact avec un cas symptomatique, la promiscuité, la non-vaccination constituent également les facteurs associés à cette maladie. Quelques actions de santé publique ont été menées. Les 136 contacts identifiés dans les 6 villages ont été suivis et vaccinés. Et nous avons mené la sensibilisation dans la communauté et les messages portés sur les mesures d'hygiène, l'importance de la vaccination et la limitation des contacts. Et nous avons également donné des messages d'orienter tous les cas suspects vers les formations sanitaires pour leur prise en charge gratuite. En vue de préserver les acquis de pallier aux insuffisances, nous avons recommandé de poursuivre la sensibilisation des maires sur l'importance de la vaccination, veiller au respect du calendrier vaccinal, renforcer la surveillance par des formations au niveau des formations sanitaires et mettre un fonds à disposition des équipes préfectorales d'alerte et de riposte pour les investigations et de riposte aux maladies à potentiel épidémique et événements de santé publique. Voici quelques références qui nous ont permis de faire notre travail et je vous remercie pour votre aimable attention.
Thank you very much. We've listened to 4 presentations. All of them were in French. So yeah, I really hope that we've captured something and learned something. Our last presentation is on the outbreak investigation, Greater Francistown District, Northern Botswana, 2023. The presenter is Utwang Modise. Welcome, madam.
Good morning. My name is Utwang Modise from Botswana, Frontline Field Epidemiology Program. My presentation will be Measles outbreak investigation that was in Cholera village, Northern Botswana this year 2023. And this will be my presentation outline. Oh, thank you. That will be my presentation outline. Measles is a vaccine preventable disease that is airborne, and it is targeted for elimination in Botswana. And measles, it usually presents with fever and rash, and with either conjunctivitis, coryza, and cough. It can complicate to pneumonia, encephalitis, blindness, and possibly death. According to WHO, the incidence of measles in Botswana, it has been 0.4 out of 100 million population. That was in 2022, and that was a decrease from 408 out of 1 million population in 2010. And our coverage for measles vaccine 1, we were at 90% in 2022, and for the second dose, we're at 77%. Now, despite the achievement that we achieved from above, we recorded a cluster of cases in January 2023, that is in Chadway village, that were presenting with fever and rash. And the record or the cluster of cases, it was unknown, the increase was unknown. Therefore, we decided to investigate in order to confirm the diagnosis and to ascertain the factors that were around the kind of the increase. And on the 5th of January 2023, we had 2 children presenting into the facility with features that were simply suggestive of measles. The district was immediately notified and the lab investigations done. Within 2 weeks from the notification, we received some results confirming that the results were positive of measles. And a day after, our rapid response team was mobilized and dispatched to go and do the outbreak investigation. And during the investigation, this is what we were looking for. We wanted to confirm the diagnosis, we wanted to describe the epidemiological characteristics of the cases, and also to implement the control and the preventive measures. The Chadibe that I'm talking about is situated 30 kilometers southwest of Francistown, with a population of 7,407 according to Statistics Botswana 2022. And people that are usually found in this village are Bakalaka, Bazezuru, Barosi, and foreign nationals, notably Zimbabwe, due to its proximity. And this is the Chadibe village that I'm talking about, that is Francistown, proximal to the Zimbabwe. As part of the method, we defined a suspected case to say this resident of Chadive with generalized maculopapular rash and fever with end of coryza and conjunctivitis from the 1st of January to the 20th of February 2023. And we defined a confirmed cases to be a suspected measles case with blood sample positive for measles IgM antibody and not recently vaccinated within a period of less than 8 weeks and below. And we also went to review the records, the clinical records, patient records, the data or the immunization records in the facility. We interviewed the KV givers where we were able to get some history also. We also took blood to do investigations. Actively, we went into the village or the household to search for cases. And later, we summarized and described our data using the median, the range, and the proportions. Now, as we summarize our data, we realized that we had 24 suspected cases, of which 10 of them were laboratory confirmed positive, and 60% among the confirmed were males. With a median age of 5 years, the youngest was around 1 year, and the oldest 25 years old. All our cases, we realized that they were from the Bazizuru, the ethnicity, all of them unvaccinated. This is a kind of vaccine hesitant group. And all the cases were from within Chadibe village. Our data from the facility, according to Botswana EPI program, it shows that the coverage for the first dose within this facility was 70%, and with the second dose giving us 63%. 2 of the cases has traveled to an area with a confirmed outbreak prior to the onset of the symptoms, and this area was outside our country. Now, as part of our results, according to this graph, 10 of our cases presented with both fever and rash, and some, of course, with cough, coryza, and conjunctivitis, as I mentioned before. And when you look at the cases according to time, we've been having, according to onset, from week 52, there was a steady increase up to week 2, of course, with a pause on week 3. And later on, we realized that we also had cases increase on week 4, that we said we had 4 cases. When you look at the distribution by age and sex, most of our cases, 60% of them were males. And when you look at the age, 6 years, 10 years below was most affected, with 40% of them being between 1 year and 5 years old. And our conclusion, the investigation, it confirmed an outbreak in Chadibe village. And the outbreak was enabled by non-utilization of immunization services among the Bazezuru based on their religious beliefs. Therefore, as a team, we recommended that there is need for a catch-up campaign in order to improve the coverage, the measles coverage within the village or within the affected group, which was done by the 31st March 2023 as led by the EPI focal person or coordinator. And then another recommendation was that there must be intersectoral community engagement, which is still ongoing. And this includes the political leaders, the faith-based religious, and the district leadership and the NGOs. And there is a vaccine hesitant strategy for the community that is vaccine hesitant that is being developed. And we believe that by the 31st of December, it will be done as led from the Public Health Specialist Office. During the outbreak, we isolated and treated cases as they came. Remember, it's just a supportive treatment. And the community was also sensitized, mobilized, so that there may be an increase in uptake of facility or healthcare utilization services. They may be aware of the preventive measures. They may be aware of the other services that they can get in relation to the outbreak. Reactive vaccination was done, and this is a picture whereby some of the cases were isolated during that particular time of the outbreak. Rapid response team meeting that was held before it was dispatched to go into the field to go and do outbreak investigation. And this is one of the meetings that we had with one of the political leaders in that particular village. It was the honorable councillor with our public health specialist and the facility managers. I would like to thank the following. The study has been possible through their input: Ministry of Health, CDC, AFENET, and the Greater Francistown management team, the staff in that local facility, and my mentors. References, those are the kind of references that we used. Ladies and gentlemen, thank you for your time.
Thank you very much. Now we've listened to 5 of the planned presentations. The last one being from Botswana is a student on frontline. That was great for a frontline student. Yeah, so I hope the evaluators will also take that into account and not start marking on the absence of logistic regression and things. You know, that was frontline. Yeah, so yeah, you're on a good trajectory. Having said that, this is a point where now we go into plenary. Let's try where we'll look for clarifications, ask the presenters, and yeah, really get more meat to the bones, if there were bones, but I think they were largely flesh. So I think that is also great. We had 5 very good presentations. At this point, maybe the presenters will just take over the questions. Then at the end, I think we'll ask you to come in front so that you could respond to those questions. Having said that, let me repeat again. I think at some point, we scan that and evaluate the sessions. So, question time. Wow, wow, wow. Oh, that's good. The mic, who passed the mic? Do we have a mobile mic? Oh, yeah. So, ladies first. We'll start from here. Then, don't hijack it. Yeah, then that one, then that, then we'll come to here. I think we'll take 3 or 4, then, yeah, I think, yeah, we'll just get the questions.
Merci beaucoup. Je suis Belinda Ayumuna de la RDC. Ma question s'adresse à Idrissa. Dans sa présentation sur la rougeole, je vois qu'il a eu 4 objectifs. Il a décrit, il a décrit, il a décrit. Et à la fin, il a fait des recommandations, mais je n'ai pas vu une action de santé publique qu'il a menée sur place. C'est question de savoir, est-ce qu'il avait mené des actions de santé publique au Togo? Merci.
Bonjour tout le monde, c'est Dr Bouyagui du Mali. J'ai 3 questions pour 3 présentateurs. Donc ma première question, c'est celui de la RDC qui a présenté sur...
Just, yeah, now continue.
Ok, donc j'ai 3 questions pour 3 présentateurs. Donc la première, c'est pour la RDC, celui qui a présenté sur le tétanos néonatal. Ma question est de savoir, vous avez mené des actions de santé publique, mais à ce stade, c'est déjà fait. C'était bon que nous ayons une petite idée du résultat de ces actions de santé publique.
It seems we're having problem with, maybe it's just me, I don't know. But can we stabilize the translations? Start again, sir.
Ok. Donc, le point de la mise en œuvre des actions de santé publique, juste une suggestion. J'ai vu des images avec des visages et on peut reconnaître ces personnes. Et dorénavant, dans vos présentations, il faut essayer de masquer ces visages-là. Donc, pour la Guinée et celui qui a présenté pour la coqueluche, j'ai vu que vous avez... une couverture à peu près de 23% Et dans vos commentaires, vous disiez que, en tout cas, la couverture est élevée. Je n'ai pas très bien compris. Est-ce que vous avez un début d'explication par rapport à cette faible couverture de 23%? Ça, c'est la première question. La deuxième aussi, c'est la même chose. Le point aujourd'hui de la mise en œuvre de ces recommandations. On liste des actions de santé publique, mais nous aimerions savoir quel est l'état de la mise en œuvre de ces actions de santé publique. C'est ce qui va beaucoup nous aider. Pour la dernière présentation, celle du Botswana qui est Frontline, félicitations pour cela. Donc j'ai remarqué que vous avez, en tout cas le délai de notification et de la riposte, le délai est à mon avis très long par rapport à la rougeole. J'aimerais savoir si vous aviez une explication à ce délai long. Et la deuxième chose, c'est aussi le résultat de la campagne de réaction vaccinale qui avait été organisée. Est-ce que vous avez atteint vos objectifs? Voilà, ça c'est les questions. Merci beaucoup. Le reste là, nous allons le faire en couloir.
I think, yeah, he has already a mic, but give it to him. He's really itching.
Yes.
Yeah, but he's already up, so yeah, you have the floor, sir.
D'accord, merci beaucoup. Je suis Patrick Mavungu de la RCA. Ok, juste deux petites questions. Je pense que ma toute première s'adresserait à Idrissa. Le titre de son travail, c'était l'impact de la coqueluche. Comme a dit quelqu'un qui a déjà posé ça, il y a eu des d'écrire dans ses objectifs spécifiques. Alors moi, j'aimerais juste ajouter juste une question. Qu'est-ce qui justifie statistiquement que la baisse de tous ces indicateurs de la surveillance de la rougeole soit liée ou soit due à la Covid au vu des résultats qu'il nous a présentés? Alors, ma deuxième question, c'est à Michel. Michel nous a un peu mélangé rougeole et TMN. Je pense peut-être il était un peu focalisé à son prédécesseur qui a présenté sur la rougeole. Mais j'aimerais juste une question. Est-ce les résultats de votre étude ne remettraient pas en cause le statut d'un pays ayant éliminé la TMN, qui est la RDC, étant donné qu'une seule zone de santé a 8 cas avec une létalité à plus de 60%? Et enfin, d'accord, merci beaucoup.
Yeah.
Ok, merci beaucoup pour la parole. C'est Cosma, je suis FLTP RDC. Ma première question va au premier présentateur. J'ai vu, il a présenté un taux d'abandon à la vaccination qui était négatif. Personnellement, je voulais savoir quels les commentaires qu'il fait par rapport à ça. Je voudrais vraiment qu'il nous explique ça en profondeur. La deuxième question, c'est par rapport à M. Bakary. À mon sens, je ne sais pas comment il a pu, comme il a fait l'analytique aussi, comment il a contrôlé les biais de confusion potentielle entre le statut vaccinal et l'âge, on peut savoir qu'avec l'âge, on peut être déjà exposé à la maladie et avoir une certaine immunité passive. Alors, je ne sais pas comment il a pu contrôler ces biais de confusion. Et j'ai vu une étude transversale, mais il a plutôt présenté les risques relatifs. Alors, je voulais savoir si il a un commentaire par rapport à cela. Et la dernière présentateur, Madame Odizé, félicitations pour la qualité de la présentation. Toute une ethnie, les enfants ne sont pas vaccinés. Vous avez dit que la raison était liée à la religion. Je voulais savoir si vous avez un plan d'intervention par rapport à cela, parce qu'il y a même un danger de santé publique, qui est toute une ethnie dont les enfants ne sont pas vaccinés. Je veux savoir s'il y a des actions particulières de santé publique pour mener à cette population-là d'accepter la vaccination. Merci.
Ok. Merci. Moi, je suis Dr Bamou. J'ai juste deux questions pour deux présentateurs. Ma première question s'adresse au premier présentateur du Togo. En fait, en quoi la nécessité de mener l'enquête CAP dans la population si nous savons que la baisse de la couverture est liée à la pandémie Covid. Donc un problème de flexibilité du système. La deuxième question, c'est le candidat de la Guinée. Au vu de cette couverture vaccinale de monitorage rapide, quelles sont les actions concrètes qui ont été menées sur le terrain, sur le plan local? Merci.
Hello. Donc, moi, c'est Dr Abdoulaye du Niger. Ma question s'adresse aux collègues de la Guinée. J'ai beaucoup apprécié le thème parce que la coqueluche, c'est une maladie qui a une très grande importance dans le cadre de la surveillance et aussi en épidémiologie. Déjà, j'ai constaté que les facteurs de risque auxquels il était parvenu étaient déjà connus. C'était le manque de la vaccination et la proximité. C'est des facteurs de risque qui sont déjà décrits dans la littérature et qui sont connus. Maintenant, moi, la question que j'aimerais lui poser, c'est à savoir, est-ce qu'il a poussé loin dans ses investigations pour savoir pourquoi les enfants ne sont pas vaccinés? Ma deuxième question, quelqu'un l'a effleuré dans cette salle, c'est par rapport au design de l'étude. J'ai cru comprendre que c'est une étude cohorte qu'il a faite, mais en présentant les résultats, on se rend compte que c'est une étude transversale. Voilà. Donc, en tout cas, j'aimerais des explications par rapport à ces points. Merci beaucoup.
Merci beaucoup pour la parole. Je suis le docteur Goury, je suis du Ghana. Sur la présentation sur la coqueluche, si je ne me trompe pas, on dirait qu'il a mentionné que la couverture vaccinale réelle qu'il a trouvée était inférieure et celle que le centre de santé a mentionnée était supérieure à la norme. J'aimerais savoir, est-ce que c'était un problème de qualité de données ou il y a une autre explication par rapport à ça? Et si c'est le cas, quelles mesures avez-vous mises en place pour mitiger cette situation dans le futur? Car si le centre de santé déclare une couverture vaccinale supérieure et la réalité sur le terrain n'est pas le cas, s'il y a des interventions, il peut avoir des soucis par rapport à ça. Cette communauté peut être laissée car ils croient que la couverture vaccinale est bonne. Or, en réalité, ce n'est pas le cas sur le terrain. Merci.
Okay, so I have two questions. The first one goes to the one that presented on neonatal tetanus. We saw that he presented some vaccination coverage, but I wanted him to in context to the affected areas. So my question is, what was the TD coverage in the areas where the cases were recorded? And then the one on the measles, I want to find out what are some of the associated risk factors, apart from the one that he talks about, the vaccine hesitancy. I want to find out what is the cold chain situation in the area. Thank you.
The last one, who is it going? There are quite a number.
The measles outbreak.
Botswana. So may the presenters, 5 of them, come in front and respond.
Ok, merci pour les questions. Ça montre l'intérêt porté à cette présentation. Je crois que j'ai eu au total 4 questions. Et la première, c'était de parler de l'action de santé que nous avons amenée au niveau du Togo. Il faut dire que pour cette étude, l'action de santé, à la suite, c'était les sensibilisations que nous avons eu à faire dans les communautés pour relancer les activités de vaccination, aussi il y a eu la recommandation sur la campagne de vaccination qui a été déjà réalisée, Donc la campagne de vaccination de repos a été réalisée dans le pays pour endiguer cette épidémie. À la question, qu'est-ce qui justifie le fait que nous lions la baisse de ces couvertures à la pandémie de Covid-19? Ici, nous avons remarqué que juste à l'apparition de cette pandémie, les activités de vaccination ou les activités de santé en général n'ont pas pu se dérouler comme d'habitude. Donc il y a eu une baisse de ces activités et donc de tous les indicateurs de santé. C'est ça qui nous a amené à lier vraiment cette baisse de vaccination dans notre district à la pandémie de Covid-19. Et donc c'est juste à l'apparition de cette pandémie que nous avons constaté la chute drastique des couvertures vaccinales. Par rapport au taux d'abandon négatif, le taux d'abandon entre les 2 doses de vaccination contre la rougeole et rubéole, le fait que après la première dose, on a voulu voir si les gens reviennent pour faire la seconde dose. Et en 2019, on a constaté que ceux qui étaient venus pour la seconde dose étaient plus nombreux. C'est parce qu'il y avait quand même une relance de la vaccination qui a amené certains, qui fait que la cible ou bien le nombre de personnes vaccinées en seconde dose était largement supérieur à la première. C'est ça qui a donné ce chiffre négatif que nous avons constaté dans notre présentation. L'enquête CAP ici, dans notre étude, les données ont été prises sur le DHS2. Sur le DISH2, c'était des données tirées du DISH2. Et donc, en liant cette baisse de couverture à la COVID-19, nous sommes dit qu'il faut quand même mener une enquête CAP pour rechercher une possible hésitation vaccinale dans la communauté et les raisons profondes. C'est ça qui fait que nous avons pris ça comme une perspective pour pouvoir voir si est-ce que réellement c'est seulement à cause de la Covid qu'il y a eu cette baisse ou bien il y a aussi une hésitation vaccinale qui naît dans la communauté. Je crois que j'ai fini les 4 questions. Merci beaucoup.
Ok, Auguste Assemblée, chers évaluateurs, merci de l'attention soutenue que vous avez pu apporter à cette présentation. D'entrée de jeu, nous allons dire qu'à ce jour, il n'est pas acceptable que nous puissions avoir des enfants qui meurent encore pour des maladies évitables par la vaccination. Alors, pour ce qui est du premier intervenant, il a voulu qu'on puisse mettre les actions de santé publique dans ce rapport. Je vais d'abord ici souligner que notre travail, c'est tout un processus. C'est une investigation qui avait ses objectifs. Et les éléments dont vous cherchez, nous les avons dans les rapports des ripostes. Parce que l'investigation reste un processus qui ne s'arrête pas à la confirmation de l'épidémie, il y a une riposte. Nous avons dû amener des actions sur terrain où on a accompagné l'équipe des centres de santé ainsi que de la zone de santé à élaborer le plan de riposte. Et il y a eu la vaccination autour de chaque cas des mères en âge, plutôt des femmes en âge de procréer. Mais cela se trouve dans les rapports de riposte et ce n'était pas parmi les objectifs de l'investigation. Merci. Pour ce qui est des images, nous les avons mis comme ça parce qu'on a obtenu le consentement. Mais vous verrez, si vous observez bien, on a pris les enfants de dos parce qu'on n'a pas eu l'assentiment pour avoir les images des enfants. C'est pourquoi les mères, elles ont regardé vers le côté de la photo, mais vous allez voir tous les 2 enfants, et ils ont été pris par le dos pour qu'on ne puisse pas voir leurs images. Alors, le deuxième intervenant, il a demandé si ces résultats ne compromettent pas les statuts d'élimination du tétanos du pays. Je ne pense pas. À ce jour, bien que nous avons pu éliminer, mais la surveillance continue. Il n'est pas dit que si on a éliminé, on arrête la surveillance. Elle continue. Et déjà, dans les guides de surveillance intégrée des maladies et riposte au niveau pays, l'épidémie est déjà déclarée à partir d'un cas. C'est-à-dire quand on a un cas suspect qui a bénéficié d'une investigation et qu'il a été confirmé, c'est déjà une épidémie pour un seul cas. Et là, on n'est pas encore dans les seuils d'élimination. Mais nous pensons qu'il y a des efforts qu'il faut fournir parce que ça montre une faiblesse du PEV des routines, du programme élargi des vaccinations de routine. Et c'est d'ailleurs ça les recommandations que nous avons arrêtées dans les actions, de renforcer la vaccination des femmes en âge de procréer et des femmes enceintes en routine. Et pour le troisième intervenant, c'était question de pouvoir contextualiser et cibler les zones touchées. C'est un travail qui a été fait, mais qui ne ressort pas ici parce que ça ne faisait pas partie des objectifs. Ça veut dire qu'après ce travail, il y a eu un autre travail qui a été fait, mais qui ne figure pas dans les résultats qu'on a obtenus ici, où on devait faire une cartographie d'abord de la provenance de tous ces cas pour qu'on puisse savoir. J'ai dit ici que pour cette zone de santé, les cas provenaient des aires de santé urbaines et non pas des zones de santé rurales. Donc c'était déjà une façon de connaître d'où proviennent les cas, quelles sont les actions spécifiques qu'on pouvait mener pour quand même amener à réduire l'incidence des tétanos dans cette contrée. Merci.
Okay, thank you. I had 4 questions. The first question was, the response time from the notification was long. Why? These are some limitations from our laboratory. We are based in Francistown, and our national lab is a bit far from us, Gaborone, not only the distance, but some technicalities that side. But as much as I said, during the first time of the suspected cases, the district was notified. There was ongoing mobilization within the facility and the village. And the second question was, during the vaccine campaigns that we had, what was the results? Interestingly, our focus was on this vaccine hesitant group, of which during house to house, we managed to reach 55 of the household, and we realized there were 95 under 5 children, and almost around 38 of them were 0 vaccine. And we managed to vaccinate around 11% of them, which is still ongoing even right now. It was not only a single day event, but it's an event that is going to be continued. And then the second one was, what is the intervention plan for this vaccine hesitant group? As much as I said, as part of our recommendation, we are trying to sit down and make a strategy for this vaccine hesitant community so that we may be able and focus our attention on them. The strategy includes engagement of political leaders and faith-based leaders, since they're the ones that are leading the organization, they're leading the families. Engaging them is of ideal, and then the district community leadership also. And then the last question, if I heard very well, was the possible risk factors. We've alluded it's a vaccine hesitant, there's zero dose groups, and they also had a travel history that exposed them. They went to a certain place that had a worst outbreak of measles, even though it was outside the country. Thank you very much. I think I've answered.
Ok, merci tout le monde. Je suis très content de l'intérêt que les gens accordaient à notre travail. Et la première question a été posée par Dr Bouyaki de Mali. Excusez-moi si je prononce mal les noms. Qui a demandé, avec une faible couverture vaccinale de 28%, quelle explication que nous pourrons donner par rapport à ça. Docteur, en réponse à votre question, lorsque la flambée est survenue, nous sommes allés sur le terrain, nous avons mené les investigations. Au-delà de tout ce que nous avons fait, le suivi des contacts et la vaccination des contacts, on s'est intéressé également pourquoi cette flambée. Et surtout que la couverture administrative de la sous-préfecture était supérieure à 80%. Les réponses sont très simples. Et la zone où il y a eu le cas, c'est une zone très enclavée. Et c'est la zone qui avait fait plus de 2 ans où le frigo pour la conservation des vaccins était en panne. Et ensuite, l'agent de santé qui est là-bas, et surtout dans la majorité d'ailleurs de nos centres de santé, plus de 90% des agents de santé, c'est des bénévoles, c'est-à-dire ne sont pas de la fonction publique, ils travaillent à titre de bénévolat. Donc, et ensuite, et il n'y avait pas aussi de logistique roulant, et toutes ces causes-là ont conduit à une faible stratégie avancée dans la communauté. Voilà. Et localement, et c'est la même question que Dr Bamou a posée, parce qu'il fallait résoudre ce problème-là localement. Localement, qu'est-ce que nous avons fait? Nous avons aussi trouvé le salaire minimum de base que nous avons donné à tous nos agents PEV qui sont chargés pour la vaccination et qui ne sont pas de l'État. Et je crois que ça a été donné selon la grille que le pays a voté. Et cela a suscité une grande motivation. Et aujourd'hui, les agents de santé évoluent en réseau. Partout où il y a une faible couverture vaccinale, ils vont pour faire le rattrapage. Et plus loin, le pays vient d'organiser une journée nationale de vaccination. Pendant cette activité, et ça a été couplé au rattrapage des enfants en pentavalent, surtout qu'après la préfecture de l'Eloma, d'autres districts aussi ont notifié le cas. Donc ça a été une riposte à l'échelle presque nationale. Voilà. Et toujours, le docteur a posé quel a été l'impact. Toutes ces actions que nous avons menées nous ont permis de rompre rapidement la chaîne de transmission et nous avons pu sauver les enfants. Les 83 cas ont été pris en charge et personne n'est décédé. Donc ça, c'était vraiment l'impact de ce que nous avons fait sur place. Docteur Kasmar, excusez-moi si je prononce mal le nom, qui a demandé qu'il a tendance aussi, comme si j'ai fait une étude transversale au lieu d'une étude de cohorte. Docteur, c'est bel et bien une étude de cohorte que nous avons menée. Si vous avez vu, nous avons pris les exposés et les non exposés, c'est-à-dire les malades et les non malades, et nous avons calculé, c'est les risques relatifs que nous avons calculés, alors que dans l'étude transversale, c'est, comment on appelle, le risque de prévalence qu'on allait calculer. Voilà, je crois que le docteur Bamou a posé la question par rapport à l'action locale. Je crois que j'ai répondu à la question. Et voilà. Docteur, toujours, bon, il y a un docteur qui a posé la question que je n'ai pas retenu son nom. Pourquoi les enfants ne sont pas vaccinés? Donc, je viens d'expliquer ça, pourquoi les enfants ne sont pas vaccinés. Docteur Bonodong de Ghana. Nous avons dit que la couverture vaccinale de la structure est élevée. Et est-ce que c'était une qualité des données? Je dis oui. Au fait, la couverture que le centre a toujours affichée, cette couverture, en le prenant, elle était toujours supérieure à l'objectif du plan pluriannuel complet, qui est supérieur ou égal à 90%. Mais lorsque nous avons mené l'enquête de couverture sur le terrain, nous avons trouvé que c'est un déphasage. Et donc, il fallait mener des actions sur le terrain pour vite corriger ce problème, pour ne pas que d'autres situations de ce genre puissent survenir. Alors, quelles sont les actions locales? Je crois que j'ai bien répondu aussi à cette question. Et si je ne me trompe pas, ce sont les questions que j'ai reçues. Et je vous remercie pour votre aimable attention.
So thank you, the presenters, for, I think, eloquently answering all the questions that were before you. May we clap hands for them. It was really, they have done a wonderful job. And we were also a wonderful group. Yeah, we interacted and we asked questions. That shows that we are attentive. May we clap hands for ourselves, please. Having said that, we'll be breaking for tea for 15 minutes. And after that, we'll come back for another session on vaccine preventable disease and public health strengthening, to be moderated by Dr. Hussein Abubari Muhaidin, something like that. I'm sorry for, you are the one. I'm sorry. Yeah, so yeah, let's go for tea break. But
to come the front cities. Yeah, it's okay. You can see. Now I would like to call here to present Mr. Franz Muwati. Welcome.
Okay, good morning to the moderator, our evaluators, and everyone in the auditorium. My name is Francis Mwenya, and welcome to my poster presentation under the title, assessing awareness, associated factors, and acceptance levels of COVID-19 vaccines among marketeers and their customers at Main Masala Market of Ndola District in Zambia, January 2023. As we are all may be aware, COVID-19 became a public health threat, and vaccinations remained paramount in curbing the disease. By December 2022, the prevalence of COVID-19 in Zambia stood at 1.78% with a case fatality rate of 0.01. The general objective for our field investigation was to measure COVID-19 vaccine acceptability and acceptance, COVID-19 vaccine acceptability and associated factors among marketeers and their customers, while specific objectives included to determine COVID-19 vaccine acceptability levels, and the second objective was to identify factors associated with low vaccine acceptability. Under methods, a descriptive cross-sectional study utilizing quantitative methods was used, and probability proportion to size was applied, while sampling, we used systematic sampling. A questionnaire was used to collect data. Results, as you can see from the results, the majority of our participants were females representing 62.3%, and then the majority were those, in terms of age range, the majority were those aged between 36 to 45 years, representing 46.8%. And then under marital status, the majority were married, representing 9.9%. And education status, the majority of our respondents had at least attained secondary education. And then to achieve my first objective, we first of all looked at commodity availability and accessibility. So all the respondents consented that the vaccine was readily available and the vaccine was easily accessible, because at our study site, the facility was just within reach. It was within a space of 100 meters. And then coming to the actual measurement or achieving of my first objective, under vaccine acceptability, only 31% of our study respondents had at least received a single dose of either Johnson & Johnson, Pfizer, or AstraZeneca. And then under associated factors, 3% had attributed non-taking of the vaccine to lacunas in the public health law, 6% due to religion, 5% had no confidence in the vaccine, and 4% had attributed their refusal to COVID-19 being a hoax. And then 8% indicated to say, sorry, they had not received the vaccine because of the myths that were surrounding the COVID-19 vaccinations. And then perception stood at 74% because people were not aware of what would happen to them had they taken the vaccine. Discussions. The Public Health Act Cap 295 of the laws of Zambia doesn't outline the punishment to be given when one refuses to comply with an intervention, even during the public health emergencies such as COVID-19. And then some religious groupings refused vaccination on the basis of their faith, and other Christians attributed the vaccine refusals as linked to receiving mark of the beast. For those who are Christians, they don't understand this very well. And then people had no confidence in the vaccine because of the short duration that it took to develop the vaccine. So as if you remember under social demographic factors, most of these people had at least attained secondary education. So they were able to research on their own, and they understood that the vaccine formulation process takes stage 1, 2, 3, and 4. Henceforth, they were hesitant to receive the vaccine. And then the information that flooded social media with misinformation led people to perceive COVID-19 as a hoax, because they thought the Western world just wanted to make money out of it. And then myths that surrounded COVID-19 included people turning into zombies, blood clotting when they receive a vaccine, and even dying after 2 years after receiving the vaccine. And then poor perception came about mainly because of social media propaganda. And then other factors included the notion that locals had a stronger immunity than our colleagues in the Western world, as attributed by the case fatality rate that stood at 4.1% in the Western world and 1.2% in Africa. In conclusion, COVID-19 became a public health threat and exposed most health systems. Thank you.
Thank you very much, Dr. Francisco. And here we go. The next one. Factories association with the uptaking of COVID-19 vaccination in adult population, Asad Kasim Sod, North Central Municipality, Region Ghana, Dr. Abdul Ghaffar.
Okay, good morning to you all. My name is Ghaffar Mohammed from Ghana, and I'm presenting on factors associated with uptake of COVID-19 vaccines among the adult population of Asante-Achem municipalities of the Ashanti region of Ghana. Vaccination has been covered as one of the cost-effective interventions against public health emergencies and diseases worldwide. Despite its proven effectiveness, hesitancy towards its uptake and reversal of taking of these vaccines has exposed the world to numerous disease outbreaks in the past. In the wake of the COVID-19 in Ghana, Ghana was one of the few African countries to deploy COVID-19 vaccines for uptake in March 2021, with a target of attaining at least 80% uptake by the end of 2022. Yet, in December 2022, less than 70% of the population had received the vaccine despite its availability. And in the Asante-Achem municipalities, less than 50% of the population had received this vaccine. We therefore conducted this study to assess the factors influencing the uptake of these vaccines despite its availability in the municipality. This was a community-based cross-sectional study in the Asante-Achem municipalities involving 344 adults. Asante-Achem municipality is one of the districts or the municipalities in the Ashanti region, which is located in the middle belt of Ghana. The municipality is mainly rural, with over 70% of its population being the rural setting. Like I mentioned, the study was conducted among 344 participants, sampled using a multi-stage sampling approach from the community. Data was collected via face-to-face interviews using a semi-structured questionnaire developed and deployed by research assistants. Data collected was analyzed using data descriptively, and a logistic regression analysis was performed to assess the factors associated with this uptake level. Out of the 344 participants studied, almost 80% of them were from the rural setting. And in terms of age, majority of them were between the ages of 21 to 30 years. In terms of religion, majority of them, that is almost 81% of them, were Christians. Now, out of the 344 people studied or adults studied, 75% of them, that is 258, had received at least a single dose of the vaccine. However, 25% of them, that is 86 of these adults, had not received any vaccine of COVID-19 at all. We proceeded to look at the factors influencing their decision to take up the vaccines, and we came up with 4 main factors, including awareness of COVID-19 vaccination, having an underlying condition, positive perception of COVID-19 vaccine safety, urban residents, and having a vaccinated relative. Adults who were aware of the COVID-19 ongoing vaccination had a 4.2 increase also receiving the vaccine compared to those who were not aware of the ongoing vaccination. Also, adults who had a chronic or underlying condition had a 4.8 times increase odds of receiving the vaccine compared to those who were not aware of those who did not have an underlying condition. Conclusion, our study revealed that less than 80% of the population, which was expected to have received the vaccine in the municipality, had actually received the vaccine. And these were the predictors or the factors we found to significantly influence the uptake of the vaccines in the municipality. That is urban residents, having a vaccinated relative, having a chronic or underlying condition, and being aware of the ongoing COVID-19 vaccination campaign. These are our recommendations. We recommend that the National Commission on Civic Education in the Asante municipalities should implement a health education in communities to demystify the perception of COVID-19 vaccine safety. And also, looking at the fact that most of these people were rural settlers, we recommend that more vaccination campaigns should be rolled out to the rural setting to increase uptake. To contribute our quota to increase the uptake of COVID-19 vaccines in the municipalities, we conducted the following activities. Public health actions. The first one we did was we engaged the communities on the importance of taking the COVID-19 vaccines and to demystify the perceptions they held against the uptake of those vaccines. Aside this, we engaged the district health information management teams on innovative measures on how to get through to the people to actually receive the vaccines. I acknowledge the following people. Thank you.
Thank you, Abdikafar, for you keeping your time. I will now, Blissel. Abandon. Yeah. The determinant of COVID-19 vaccination acceptance among eligible residents, community-based cluster survey. The presenter and come here abundant, please.
Good morning, ladies and gentlemen. I am Abiodun Kolapo, a Cohort 11 graduate of the Nigerian FATP. I'll be presenting the key findings of a cluster survey on the determinant of COVID-19 vaccine acceptance among residents of Ilorin Metropolis, Nigeria 2023. By way of introduction, the COVID-19 pandemic started as a pneumonia-like infection in China, December 2019. And the first Nigerian case was reported on the 27th of February 2020. It was noticed that vaccine acceptance was critical to achieving herd immunity and protection of the vulnerable. In a survey conducted by the African CDC in partnership with the London School of Hygiene and Tropical Medicine, it was reported that 80% of Africans had the intention of receiving the vaccine, including people in Nigeria. However, at the time of this study, only 51% of the eligible population had been fully vaccinated. Therefore, we conducted this study with the aim of determining, number one, to determine the prevalence of COVID-19 vaccine acceptance. Number two, to identify reasons for non-completion of the primary vaccine schedule. And then number three, to determine factors influencing acceptance of COVID-19 vaccine. The study was carried out in Ilorin, the capital city of Kwara State, and the largest urban center in a state called Kwara in Nigeria, shown above. Ilorin is in yellow in the map shown above. The study was a community-based cross-sectional three-stage cluster survey involving 861 consenting adults who had lived in Ilorin metropolis for at least 3 months consecutively. In our sample size calculation, we used a design effect of 2. We factored in the non-response, and then we sampled our respondent from 30 enumeration areas, selected probability proportional to size, and we we determined the direction of data collection using the spinning bottom method, and we selected households using the principle of next nearest household. We selected eligible respondent in every household. We used the 7C vaccination readiness scale to capture the information of our respondent. The 7C consists of confidence, collective responsibility, calculation, complacency, constraint, compliance, and conspiracy. Each of the 7 components was assessed by a 3-point Likert scale. We conducted descriptive statistics and logistic regression. We considered the p-value of less than 0.05 as statistical significance. Ladies and gentlemen, I present to you the result of our finding. The mean age of the respondent was 34%. Majority, about 63%, had some form of tertiary education. About 76% believe in the existence of COVID-19. About 61% had received a vaccine as at the time of this study. The most common reason for non-completion of the primary series was the claim to having enough immunity. This was a multiple choice question, and majority of this is a count measure. Majority of those who had received only one cited having enough immunity as a reason for not taking the subsequent doses. Bivariate analysis showed that factors associated with COVID-19 vaccination included age, marital status, belief in the existence of COVID, then knowing someone who had been infected with COVID-19, and having a history of COVID-19 infection, including all the components of the 7C scale. However, in the multivariate logistic regression, only age, especially the early middle age, 40 to 49, and then confidence, complacency, higher levels of confidence and collective responsibility, and then lower levels of constraint, conspiracy, and complacency. Thank you. Well predicted. Thank you very much.
Thank you very much. Yes, the another one. Allow me a better. Absent. Yeah. Allow me as absent. The another one, Patrick King. COVID-19 vaccine uptake and coverage in Uganda, March 2021. Patrick Keane, you will represent. Welcome.
Good morning, listeners. Patrick King is my name. An advanced FETP, here to present COVID-19 vaccine uptake and coverage in Uganda from March 2021 through June 2022. COVID-19 has had a big negative impact globally. It is responsible for over 500 million infections and over 6 million deaths. COVID-19 vaccine could reduce COVID-19 related mortality and morbidity. Uganda began vaccination in March 2021 after receiving vaccines from the COVAX facility. We adopted the World Health Organization Global Strategy on COVID-19 vaccination, targeting a national coverage of 10% by September 2021, 40% by December 2021, and 70% by June 2022. We assessed COVID-19 vaccination in Uganda to evaluate progress towards the WHO targets and also identify gaps for evidence-based recommendations. We conducted an analysis of secondary data from the National COVID-19 Vaccination Database for the study period. Vaccine uptake was defined as the proportion of the proportion of the population vaccinated with at least one COVID-19 vaccine dose, while coverage was defined as the proportion of persons who had received the full number of doses of the relevant vaccine. For single-dose vaccine, uptake equaled coverage. For the first 2 quarters of 2021, vaccine uptake was low. This could be linked to insufficient number of vaccines available. Vaccines were only available at health facilities. However, there was a rapid increase of uptake from quarter 3, 2021 to quarter 2, 2022. During this period, accelerated mass vaccine campaigns were ongoing in the country. Uptake was 68% by the end of June. Coverage followed the same trend as uptake. However, it was consistently below the set WHO targets. By the end of June 2022, coverage was 28% less than the set target. Both uptake and coverage were higher among females than males. Persons above 50 years had a higher coverage and uptake compared to younger persons. This could be attributed to longer periods of vaccine accessibility in this status as a targeted group, or widespread information about older persons being at higher risk of COVID-19. Although vaccine coverage was suboptimal in regions, Western region had significantly higher coverage than other regions. This could be due to accelerated mass vaccination campaigns in the region. Overall, approximately 25 districts, most in the southern half of the country, attained COVID-19 vaccination greater than 70%. 10 districts, mainly in the north and northeast, were lagging behind with a coverage of less than 5%. Generally, Uganda fell short of the set targets of the World Health Organization. The COVID-19 upset and coverage were increased when the vaccination strategy changed from static to accelerated vaccination. Continued vaccination in the higher priority groups could facilitate increased coverage. And then programs to continuously track vaccination progress need to be intensified in order to increase coverage. We acknowledge the following. Thank you.
Thank you for your keeping the time, Mr. Kane. I will now to start the next one. See by then. Thank you. Post-outbreak assessment predatories of whole measles vaccination is among children aged 24 to 59 months at Tembu, Amanti District, Ghana, 2020. And will present Inuso Abidan. Welcome.
Good morning. My name is Eunice Baden-Lai from Ghana, and I'll be presenting on predictors of full measles vaccination among children aged 24 to 59 months in Atebubu Mountain District, and this was a post-outbreak assessment. Though measles elimination has seen several milestones through vaccination, in 2018, an estimated 169 million children still missed the first dose of the measles vaccine globally, and this led to an estimated 140,000 deaths in 2018. Ghana has, however, achieved great strides in measles vaccination, achieving a coverage of over 95% in 2018. And early 2019, the country was recognized as one of the 5 countries in the African region to reach this regional target. Zooming into Atebubu Mountain District, our area of focus, this district has recorded consistently high measles vaccination coverages, above 95% since 2016. And in 2018, the district actually recorded a 97% vaccination coverage for the first dose. Given such high coverages, we do not expect an outbreak to occur in such a district, given that measles herd immunity is attained at 95% vaccination coverage. However, this district recorded an outbreak in 2018 consisting of 23 children, and previously had also seen some focal outbreaks. The problem here is these high coverages I am mentioning are calculated administratively, which is affected by erroneous estimation of the total population. We therefore sought to determine the measles vaccination coverage and predictors of full measles vaccination in the district. It was a cross-sectional study using a mixed methods approach. The district has an under 5 population of over 25,000, 11 health facilities, of which 9 offer immunization services. For data collection, for the qualitative methods, we sampled all the 9 health facilities in the district and also all the 26 health workers and interviewed them on health system factors influencing vaccine uptake. For the quantitative methods, we conducted a community-based survey using a 2-stage cluster sampling method and sampled 400 caregivers and interviewed them on the caregiver-related factors influencing vaccine uptake. We calculated measles vaccination coverage as the proportion of children receiving either 1 or 2 doses of the vaccine, and also used multiple regression analysis to explore the predictors of full vaccination. 91% of the children had received the first dose of the vaccine, while 80% had received the second dose. For caregiver-related factors, living in an urban area and being a child of a trader was associated with reduced odds of being fully vaccinated, while caregivers who had increased knowledge on measles vaccination was associated with increased odds of fully vaccinating their children. For the health system factors, vaccine shortages led to missed opportunities, which resulted in low uptake, whilst EPI policies such as defaulter traces and then health education led to increased uptake. In conclusion, measles vaccination coverage was below the herd immunity threshold, which was 95%. But given that it was 91%, should this really be yielding outbreaks? Could it be that the children are not seroconverting? That is something to discuss. Living in an urban area and being the child of a trader were negative predictors of full vaccination, whilst EPI policies such as defaulter tracing boosted uptake. We therefore recommend that the District Health Directorate should set up vaccination posts in market to vaccinate children of traders, and also increase health education, especially in urban areas, and enforce some of the EPI policies such as home and school visits. For our public health action, given that it was a post-outbreak assessment, we identified some suspected cases of measles during the survey and sampled them for testing, one of which tested positive. Also, we supported the districts to conduct a mop-up vaccination campaign. This was me going to an overbank community to support with the campaign. We would like to acknowledge the following organizations. Thank you.
Thank you very much. Now we are finishes the speeches of the presenters. Now we are starting the questions and answers. Who is asking any question the presenters? One, two, three. %.
Merci pour la présentation. Ma question s'adresse à la dernière représentation. Je voulais savoir la stratégie. Merci pour les intervenants, pour ces belles représentations. Ma question s'adresse particulièrement à la dernière représentation. Je voulais savoir les stratégies adoptées pour cette couverture vaccinale qui est très, très, très élevée. Merci beaucoup.
Merci à tous les présentateurs. Ma question est générale pour tous les présentateurs, à savoir, on fait une action de santé publique, on fait une étude pour une action. Chacun a présenté ce qu'ils ont eu à faire après l'étude, mais on n'a pas vu l'impact de ce qu'ils ont fait, ce que je voulais savoir.
Okay, thank you all for the wonderful presentation. So my question is to the first presenter. I have two questions actually. So to the first presenter, you mentioned you used systematic sampling for recruiting your marketeers and then your customers. Can you throw a bit of light on how you did that in the market? Then to the fourth presenter, the last presenter from Ghana. So you mentioned your sample size was 400. Can you explain a bit how you got the 400 and how you sampled your participants? Thank you.
Oui, bonjour. Je m'appelle Abdel Hussein, je suis de Djibouti. Ma question s'adresse à mon collègue du Ghana, parce qu'il a dit que la vaccination de Covid et ses obstacles. Là, on comprend que, en général, en Afrique, c'était la vaccination, la campagne de vaccination était priorité pour l'État. Mais la présentation qu'il a faite, c'est comme si l'État était à part. Il dit que la vaccination et ses obstacles. Ce qui veut dire que, moi j'ai demandé la question, quel est le rôle de l'État? Parce que c'était obligatoire, la vaccination était obligatoire. Surtout les personnels qui travaillaient dans les fonctions publiques. Merci.
Okay, thank you very much. So my question goes to Mr. Abdul. You highlighted 4 main factors that influence vaccination uptake. Were these the only factors you considered? If there were any other that you could share with us, thank you.
Okay, thank you. My question goes to colleague from Ghana who present COVID-19 vaccination, and he recommend to continue vaccination for COVID-19 to increase the coverage. According to the context of COVID-19 presently, I want to know for which public action, what you want to get for continuing to increase the COVID-19 vaccination coverage. Thank you.
Okay, I think I have a, can I go? Okay, so I want to, my question goes to the last presenter. Thank you for your great presentation, and I'm much happy that your public health actions led to some detection of cases. But in terms of the vaccination coverage that you did, I just wanted to know the number of children that you were able to vaccinate. I think you were in a boat going somewhere. So we want to know how many children were you able to vaccinate out of that. Thank you.
Thank you to the presenters. Really, these were interesting studies. To the first presenter, Francis, I just wanted to know whether you had any other rigorous statistical method you would use to arrive at associated factors, because I saw you presented proportions and you seem to have based on that to arrive at associated factors, yet we needed to know. And maybe you can also tell us if you went ahead with that to implement any public health action. Thank you.
Okay, I want to, all the presenters come to here and answer the whole questions.
Okay, good morning, everyone, once again. I have 3 questions. The first one, the first question is talking about the public health actions that we took after doing this study, and did we have any impact? Yes, as I indicated in my preamble in my study, when we conducted this survey, the vaccination acceptance levels were at 31%. And then arising from the submissions that we made to the Ministry of Health and the local authorities from the markets, there was intersectoral collaboration, and then a lot of players came on board, and there was sensitization in the markets. And later we saw that people started flocking to the facility to receive vaccinations. And then the second question is on sampling. I've been asked to explain how the sampling was done. So as I indicated, probability proportion to size was used. So the first step was to identify clusters. So in the market, we had about 4 clusters. So we had the actual marketeers, then we had customers, and then we had cowboys in the market, we had restaurant owners, and then we also had those who had taverns. So in each cluster, we had to come up with a sampling frame. And then after getting the sampling frame, the systematic sampling was actually done at cluster level. So we had the sample size for this study was 286. So each cluster was actually allocated its appropriate proportion for the number of people to be sampled. And then the third question is on, I've been asked to explain if I'd used any vigorous statistics. So one of the limitations actually of my study, it was a descriptive cross-sectional study, and we only applied a quantitative method. So we had actually we had collected qualitative data, but then the challenge that we had then, I was using my mobile phone, and accidentally it had actually misbehaved. So that was one of the limitations of my study. So our analysis was actually based on the quantitative methods that we had actually used. Thank you.
Okay, thank you very much for the questions. I had about 3 questions. The first one was a general question to all of us, which looked at the effects of our public health actions we implemented. Like I mentioned prior to the study, we had assessed or we had looked at data available on the DIMS platform on the uptake level of COVID-19 vaccines in the municipality, which was 43%. That was prior to the study. After the study, that is 7 months after the study, we went back to the system and we actually had an increase in the level of uptake, which is 66%. I can't say the public health actions we implemented caused this increase, but might have contributed to an increase in the uptake of the vaccines. Now, the next question I had was if I considered only the factors I presented here. Because it's a poster, I didn't present all the factors that I ran at the crude logistic level. I only presented the factors which were significant at the adjusted logistic regression level. That is why you had only 5 factors on my poster. Now, the next question, my good friend mentioned that the importance of the state in ensuring that the populace get the vaccine, instituting policies, making it mandatory, though it is possible in some countries, and though some institutions adopted it, particularly the private ones. If you're an employee and you're not vaccinated, you'll not be allowed into the system. But it's not every institution in Ghana that adopted that approach. So, and also you also realize that urban setting had an increase also of getting people vaccinated. Now, most of those who are not vaccinated were in the rural setting. How many organizations do we have in the rural setting who will say, if you don't get the vaccine, you not come to my institution? The farms, you can't say, if you don't get the vaccine, you go to the farm. So that's basically why that particular approach did not actually work very well for us. Now, so to the last question, which the mandatory vaccination in some institutions, just answer that. Okay, so this is the basic questions I had. The other one was a general question and I answered it first. Thank you. That one was a general question and I answered it first. Thank you.
Thank you very much. So my first question was host-based vaccination, home visits, and that is some of the EPI policies I mentioned. I talk about these efforts because when we were doing the survey, we decided to go by card and history, but we realized that every person we attended to had a card. That means that these people have actually been reached, but there's one thing, being reached with the vaccine, and then they get into the 9 months and actually taking the measles vaccine. So the next one, I arrived at 400, and then, so the 400 was using Cochrane sample size estimation for infinite population. We used confidence interval of 95%, 75% vaccination coverage. We looked at 1.2 design effect and also a 10% non-response rate. And as I mentioned earlier, it was a 2-stage cluster sampling. The first stage, we selected enumeration areas. The second stage was the household selection, which was based on probability proportionate to size of the enumeration area. And also, in each household, we selected one eligible child by drawing lots. The next question was, how many children? I'm not too sure if it was, did I vaccinate? Or the whole, yes. So we actually got 812 children vaccinated. The last question, which was the general question about the public health, effects of the public health actions. As I mentioned, we were able to get one case, which another important thing was that it's made the district aware that we shouldn't be too comfortable with the high vaccination coverages we are seeing, but we should really do more in getting higher coverages. Thank you.
Thank you very much. I am very glad I had a good time with you. Thank you all. Our program is finished. I remind you everyone to scan and for voice. Thank you very much.
We are heading to plenary session 2.
Wrongly. She'll be presenting on factors associated with hypertension among persons living with HIV in Mombasa County, Kenya. And the third presenter will be Fatmata Mukalia Issa. Did I get that right? All right. And she'll be presenting on prevalence of cardiovascular emergencies and associated factors. Case of the emergency department of the National Hospital of Niamey, Niger, February to March 2020. Correct? And the last one is Seaford Sol Tibabara, and we're presenting on prevalence and risk factor of hypertension among adults in Tanga region in January 2023, a cross-sectional community-based survey. So we're expecting presentations from these three presenters. If they are here in the hall, I think we are going to start because we are already behind schedule. And I'll be very strict with the time because you will be standing between us and the lunch. Is that okay? We'll be giving 5 minutes. So please, you have to summarize your presentation. Is it 10? Now I was told it's 5 per presentation. Sorry? Okay, it's 10. How many minutes do we have for Q&A? All right, so could we please manage to stay within that 10 minutes? Is that okay? I think that is the good for the better for all of us, if we keep within time. All right? Okay, so I will... Okay, I think they're there. I know that. Kaita is there. Dr. Kaita, are you not one of the evaluators? Yes. So both evaluators are here. All right, so we are good to go. All right, so with that said, I want to thank you very much. Maybe I forgot to introduce myself before, I'm so eager to get this thing done quickly so that we can go for lunch. I'm Dr. Vandi. My name is Dr. Vandi. I'm the Director for Health Security Emergencies, Ministry of Health. At the same time, the Country Director Program Director for FETP Sierra Leone. Nice to be with you. So it's my pleasure to call to the podium the first speaker. You have 10 minutes, and your time starts now. Thank you.
Merci, Monsieur le Président. Bonjour l'assistance. Je suis Dr Moussa Ahmadou. Je suis FLTP gradué. Je viens du Niger. J'ai le plaisir de vous présenter ce travail intitulé « Analyse des données du registre national des cancers du Niger pendant la période de 2010 à 2018 ». Pour cette présentation, je vais suivre le plan suivant. Après une introduction, je vous présenterai les méthodes qui m'ont permis d'aboutir à des résultats que je vais discuter avant de tirer une conclusion. En introduction, le cancer est une maladie dans laquelle certaines cellules du corps se développent de manière incontrôlée et le cancer peut commencer dans n'importe quelle partie du corps. Il s'agit d'un problème de santé publique. Le cancer fait partie des 4 MNT, maladies non transmissibles majeures, et c'est la deuxième cause de décès par MNT. Dans le monde, en 2020, selon l'Agence internationale sur la recherche sur les cancers, environ 20 millions de cancers ont été notifiés, dont les 50% dans les pays en développement. Au Niger, Selon une analyse du registre national de cancer pendant la période de 1992, année pendant laquelle ce registre a été mis en place, jusqu'en 2009, au total, les cas ont évolué de 186 à 646 cas. Après cela, il y a eu certaines réformes, dont notamment des campagnes de dépistage sur le terrain, la mise en place d'un deuxième laboratoire national d'anatomopathologie, la création et la mise en fonction d'un centre national de lutte contre le cancer. Il nous a paru donc opportun de faire une mise à jour de l'épidémiologie et nous avions décidé d'analyser des données plus récentes. Nos objectifs, c'est pour voir l'évolution des cancers, décrire les cas, mais aussi décrire la mortalité liée au cancer. Sur ces cartes, vous voyez un peu la situation du Niger, un peu de l'Afrique de l'Ouest, avec une superficie de 1 267 000 km², 8 régions sanitaires, 72 districts sanitaires, avec une couverture sanitaire de 50%. Donc le système est organisé à 3 niveaux. C'était une étude descriptive menée du 1er mars au 30 mai 2022. Nous avions considéré tous les cas de cancer notifiés et enregistrés sous le registre pendant cette période. Donc nous avons exporté les registres et les données à partir du registre CANREG 4 vers Excel avant de les traiter. Le traitement avait consisté à rétablir la topographie en utilisant la classification internationale des maladies, numéro 10. Nous avons fait nos analyses avec le logiciel EpiInfo et Excel. Nous avons calculé la moyenne des fréquences, mais aussi des proportions, et nos résultats ont été présentés sous forme de tableaux, de graphiques et de textes. Sur ce premier graphique, nous avons l'évolution des cancers au Niger pendant notre période d'étude. Les cas ont évolué de 543 cas en 2010 à 1565 cas en 2018. Sur ce tableau, vous avez la répartition des cas notifiés par région sanitaire et presque la moitié des cas étaient enregistrés dans la région de Niamey, qui est la capitale. Sur ce tableau, vous avez la description des caractéristiques des cas enregistrés. La moyenne, nous avons un effectif de 5 889 cas, donc une moyenne de la moyenne d'âge est de 66,67 avec un écart type de 17,96. Les femmes étaient majoritairement touchées dans 61,32%. Sur ces graphiques, vous avez la répartition des cas de cancer notifiés chez la femme pendant la période d'étude. Donc nous remarquerons que c'était le cancer du sein et le cancer gynécologique qui étaient majoritaires avec 34% et 28%. Ce tableau nous montre la répartition des cancers notifiés chez l'homme pendant la période d'étude. Et nous remarquerons que c'est le cancer du foie et de voie biliaire suivi du cancer colorectal qui était majoritairement notifié avec 28% et 14%. Sur ce graphique, vous avez la mortalité du cancer, le délai au fait de survenue du décès lié au cancer. Et nous remarquerons que 93,38% des décès enregistrés par cancer pendant notre période d'étude étaient notifiés pendant la première année après le diagnostic. En discussion, le nombre de cancers notifiés durant notre période d'étude avait triplé. Et cela pourrait se justifier à travers l'augmentation des facteurs de risque tels que le tabagisme, l'alcoolisme, la malbouffe, la sédentarité qui ont été mises en évidence à travers l'enquête STEPS 2021 au Niger. La construction d'un deuxième laboratoire d'anapath pourrait aussi justifier cet état de fait. De toute façon, nos résultats corroborent avec les tendances des MNT dans les pays en développement, avec une tendance qui est passée de 47% en 90 à 69% en 2020. D'autres chercheurs comme Lampo au Burkina, Abdel Latif au Maroc, Hamdi en Algérie et Kadende au Burundi ont trouvé des résultats similaires aux nôtres. La mortalité pendant notre période d'étude était de 6,77% avec 93% des décès survenus pendant la première année du diagnostic. Cela pourrait se justifier par le retard dans l'identification des cas, le retard dans la recherche des soins, le retard dans l'examen cytologique, mais aussi la prédominance de certaines formes digestives. En conclusion, les cancers sont en augmentation au Niger. les femmes adultes sont majoritairement touchées. La majorité des décès survient dans la même année du diagnostic et les cancers restent sous-notifiés. Nous recommandons au ministère de la Santé publique de mettre en place un système de dépistage précoce des cas dans les formations sanitaires, de renforcer les campagnes de dépistage actifs sur le terrain, d'améliorer l'accès aux technologies modernes de traitement du cancer et de continuer à sensibiliser la population pour se faire dépister et recourir à des soins dans le meilleur délai. Nos remerciements à ces organisations. Merci.
Thank you very much, Musa, for keeping the time. I think this guy knows how to summarize. Thank you very much. We now invite the next speaker, the next presenter. Faith, is it Faith? Faith, you have the podium. How do you get? Come on here, please.
Good afternoon. My name is Faith Modachi from the Kenya FETP program, and I'll be presenting on factors associated with hypertension among persons living with HIV in Mombasa County, Kenya, which is where we are currently. So as an introduction, hypertension is defined as having an persistently elevated hypertension is defined as having an persistently elevated blood pressure for systolic blood pressure greater than 140 millimeters of mercury, or diastolic blood pressure greater than 90 millimeters of mercury, or both. In terms of the prevalence of disease for hypertension among HIV patients, globally this has been estimated to be at about 35%. In sub-Saharan Africa, this has been estimated to be at about 18%, and in Kenya, the highest recorded prevalence was at 19%. And the map on the right-hand side of your screen is from the Lancet. It shows the prevalence of disease across the world. As you can see, the greatest burden is in Africa, especially Northern Africa, where it's 30 to 34%, and also high in areas such as Asia and Europe. So the risk factors for hypertension include alcohol consumption, insufficient physical activity, high salt intake, which is greater than 6 grams per day, tobacco smoking, as well as obesity. Mombasa County was found to have a high prevalence of some of these risk factors for hypertension. Tobacco use was at 24.1%, alcohol abuse at 3.8%, and drug abuse, which was high. And so we anticipated that we would have a higher prevalence of hypertension in the county compared to other regions of Kenya. So our objectives, we had two main objectives. The first was to determine the prevalence of hypertension among persons living with HIV in Mombasa County, and our second main objective was to identify the factors associated hypertension, again in this population. For our methods, we used a cross-sectional study design. This was from December 2021 to February 2022. Our study location was in the comprehensive care centers, which is where we treat our HIV patients, and this was done in our high-volume facilities that is shown in the map on the right-hand side of the screen. For our study population, these were patients who were on HIV follow-up in these hospitals. For our inclusion criteria, we looked at patients who are of 18 years of age and above, those who are attending the comprehensive care centers, and those who gave informed consent and were residing in Mombasa County. Our exclusion criteria were those who are not physically or mentally able to participate in the study. For our study definition, we defined hypertension as anyone who had two separate readings of an elevated blood pressure, either a systolic blood pressure greater than 140 or a diastolic blood pressure greater than 90, or both, or any patient who was already found to be on an antihypertensive drug. In terms of data management, for our categorical variables, we looked at frequencies and proportions, and for continuous variables, we looked at measures of central tendency and dispersion. For calculating the prevalence of hypertension, We determined the participants that had hypertension and then divided this against all the other participants. For bivariate analysis, we calculated the prevalence ratio, and any variable that had a p-value less than 0.2 was then subjected to multivariable analysis. For multivariable analysis, we did Poisson regression, and a level of significance was a p-value less than 0.05. And then all the factors, all the variables that were subjected to multivariable analysis, we also looked for multicollinearity using the variable inflation factor, and a value of 5 or more suggested significant multicollinearity. So what were our results? We had a total of 235 participants. Their mean age was 42.8 years with a standard deviation of 10.7. Females contributed the largest proportion at 71.1%, and the age group 35 to 44 years had the highest proportion at 35%. In terms of the clinical characteristics, we found that the largest proportion of participants were in WHO clinical stage 1, that's at 88.5%, and the largest proportion of participants also had not reported to have had a history of an opportunistic infection in the previous year, that's at 91.5%. In terms of comorbidities, hypertension was the most prevalent comorbidity at 25.1%. So for the prevalence of disease, our first objective, the overall prevalence of hypertension was at 25.1%. Males had a slightly higher prevalence of disease at 26.5%. And in terms of age group, the age group above 55 years had a slightly higher prevalence at 6.4%. So we looked at various factors to see if they were associated with hypertension. We looked at sex, we looked at alcohol use, we looked at cigarette smoking, and exercise, and for this population, these factors were not found to be significant. We then proceeded to look at other factors. We looked at adherence to treatment, whether these participants were on a regimen that contains zidovudine versus whether they were on a regimen that did not have zidovudine, whether they were on a regimen that had a protease inhibitor versus whether they were on a regimen that didn't have a protease inhibitor, and whether their viral load was detectable or undetectable, and these were also not found to be significant. Then lastly, we looked at age, we looked at BMI, we looked at whether they were on a regimen that had tenofovir versus a regimen that didn't have tenofovir, and whether they had had a history of opportunistic infection. And on bivariable analysis, all these were found to have a p-value less than 0.2. So all these factors were then subjected to multivariable analysis, and the significant factors were a BMI greater than 30 was found to have a 3.37 times higher prevalence ratio compared to those with a BMI less than 25. A BMI between 25 to 29.9 was shown to have a 2.4 times greater prevalence ratio of hypertension compared to those with a BMI less than 25. And for the tenofovir-based regimen, this was found to have a 68% lower chance of hypertension compared to those who are on a regimen that did not contain tenofovir. So these variables that we looked at for multivariable analysis, we calculated the variable inflation factor. The mean VIF we got was 1.06, and as you can see, none of the variables had a VIF greater than 5, and so there was no multicollinearity. So in conclusion, we saw that 1/4 of our patients living with HIV had hypertension in Mombasa County, and this is higher than what we had seen in previous studies in Kenya. Previous studies had reported a prevalence ranging from 14% to 18%. In terms of the factors associated with hypertension, we saw that those who had a BMI greater than 25 were associated with up to a 3 times higher prevalence of disease, and this is in concurrence with multiple other studies that show that the higher the BMI and the higher the association of hypertension. We also saw that those who were on a regimen that had tenofovir had a 68% lower prevalence of disease. This was similar to one other study that was done in Nigeria, and the plausible explanation for this was that tenofovir has been shown to lead to loss of body fat and thus may contribute to a decreased rate of hypertension. Our recommendations, our first recommendation was integration of hypertension management in our comprehensive care centers. This is as opposed to our patients seeking for health services in our medical outpatient clinics for hypertension and then seeking for HIV services in the CCCs. Our second recommendation was that the patients noted to have a BMI greater than 25 should be closely followed up to monitor for hypertension and other NCDs. And lastly, that any patient living with HIV with a high BMI should be put on a tenofovir-based regimen where possible. For public health action, we submitted a comprehensive report to the Mombasa County Department of Health, and we've also submitted this for publication. I would like to acknowledge the following. Thank you.
Thank you very much. I think that was very interesting, and you also were within time. Thank you. So let me close this. Come. Here is what? This. In French? Okay. It's okay.
Merci, Monsieur le Président. Monsieur le Président, chers membres du jury, chers auditoires, bonjour. Je suis Dr Fatoumata Moukaila, je suis gradué FLTP et je viens du Niger. J'ai le plaisir de partager avec vous ce travail concernant la prévalence et les facteurs associés aux urgences cardiovasculaires à l'hôpital national de Niamey en 2020. Pour ce faire, nous suivrons le plan classique suivant. Après avoir introduit le sujet, nous verrons la méthodologie que nous avons suivie et les résultats auxquels nous avons abouti. Ensuite, nous discuterons ces résultats, puis nous conclurons. Monsieur le Président, chers membres du jury, les maladies non transmissibles sont responsables, d'après l'OMS, de 41 millions de décès à travers le monde, et ce, chaque année, ce qui en fait un véritable problème de santé publique. Les maladies cardiovasculaires, quant à elles, occupent la première place parmi ces maladies non transmissibles. À elles seules, elles sont responsables de 31 millions de décès. Et malheureusement, la plupart de ces décès, on les retrouve dans nos pays en voie de développement. Selon l'OMS, une maladie cardiovasculaire est tout trouble qui atteint le cœur ou les vaisseaux. Et malheureusement, la plupart de ces maladies surviennent sous forme d'urgence, ce qui nécessite donc une prise en charge rapide et urgente parce que c'est le pronostic vital du patient qui est en jeu. On peut citer comme exemple de maladies ou d'urgences cardiovasculaires les accidents vasculo-cérébraux, les œdèmes aigus du poumon, les péricardites, entre autres. En Afrique, les maladies cardiovasculaires sont responsables de 31 millions de décès. Il n'y a pas de chiffres sur ce sujet au Niger. Néanmoins, en 2012, il a été créé un programme national de lutte contre les maladies non transmissibles. Et en 2018, l'hôpital national de Niamey rapportait que 21% des admissions au service des urgences étaient des maladies cardiovasculaires. Ainsi, pour combler ce gap, nous avons décidé d'étudier la prévalence et les facteurs associés aux urgences cardiovasculaires à l'hôpital national de Niamey et en 2020. Et pour atteindre cet objectif, nous avons utilisé la méthodologie ci-après. Notre étude s'est tenue à Niamey, la capitale du Niger, plus précisément à l'hôpital national dans le service des urgences médicales. Nous avons mené une étude descriptive analytique allant de février à mars 2020. Notre population d'étude était l'ensemble des patients admis de plus de 15 ans au niveau des services d'urgence médicale. nous avons utilisé la formule de Schwartz pour calculer notre échantillon et la taille totale de notre échantillon était de 422. La variable dépendante était l'urgence cardiovasculaire et les variables indépendantes étaient variées. Il y avait l'âge, le sexe, les antécédents personnels, hypertension artérielle ou diabète. Il y avait par exemple le tour de taille, l'indice de masse corporelle, les facteurs sociaux culturels, par exemple la perte d'un être cher. Concernant les analyses, pour le descriptif, nous avons estimé des fréquences, des moyennes et fait des comparaisons. Et concernant la recherche étiologique, nous avons d'abord en analyse univariée estimé des ordres ratios bruts où le seuil de significativité était une p-value inférieure ou égale à 0,20 avec un intervalle de confiance de 95%. Et en analyse multivariée, nous avons estimé des ordres ratios ajustés où le seuil de significativité cette fois-ci était une p-value inférieure à 0,05. Nous avons traité nos données avec Excel 2019 et EpiInfo dans sa version 7.2. Et avant administration du questionnaire et examen des patients, le consentement de tous les patients a été obtenu. Ainsi, Monsieur le Président, chers membres du jury, chers auditoires, en suivant cette méthodologie, nous avons abouti aux résultats ci-après. La médiane d'âge de notre échantillon était de 50 ans. Nos patients avaient de 15 à 102 ans. Le sexe ratio homme sur femme était de 1,03 et la létalité était de 13%. L'échantillon total était de 422. Sur les 422 patients, 116 étaient venus pour une urgence cardiovasculaire, ce qui faisait une prévalence de 27,5. Quelles étaient les principales urgences cardiovasculaires reçues? C'était d'abord l'accident vasculo-cérébral, ensuite la poussée hypertensive et enfin l'insuffisance cardiaque. En analyse univariée, nous constatons que l'âge, l'antécédent personnel d'hypertension artérielle, le tour de taille supérieur à la norme par rapport au sexe et le temps passé assis sont significativement liés à la survenue d'une urgence cardiovasculaire. Mais après ajustement, nous constatons que l'âge et l'antécédent personnel d'hypertension artérielle étaient ceux qui étaient indépendamment liés à la survenue de l'urgence cardiovasculaire. Monsieur le Président, avec votre permission, nous allons discuter nos résultats. La prévalence des urgences cardiovasculaires dans notre étude était de 27,5. À Bamako en 2015 et au Cameroun en 2012, des résultats inférieurs ont été retrouvés, simplement parce que dans ces études, elles ont eu lieu dans un service d'urgence qui recevait en même temps des urgences médicales et des urgences chirurgicales. C'était sur une période, il n'y avait pas d'échantillonnage et nous sommes d'accord que le nombre d'urgences cardiovasculaires qui va arriver sera très petit. Par contre, à Kinshasa, en 2015, un chiffre plus élevé a été trouvé pour la prévalence parce que cette étude-ci, à son tour, elle a eu lieu dans un service de soins intensifs. Et dans les services de soins intensifs, ils recevront plus les malades inconscients, par exemple, liés à un AVC, à un accident vasculo-cérébral, plutôt, par exemple, qu'un paludisme simple ou une pneumopathie simple. L'urgence cardiovasculaire la plus fréquemment retrouvée était l'accident vasculo-cérébral. Il en était de même à Kinshasa en 2015 et à Libreville en 2017. Par contre, au Sénégal, SAR a trouvé que le syndrome coronarien était le plus fréquent. Il faut dire que dans les conditions d'études de SAR, les moyens diagnostiques étaient beaucoup plus présents que dans notre cas. Concernant les facteurs associés, nous avions retrouvé que l'âge et l'antécédent personnel d'hypertension artérielle étaient indépendamment liés à la survenue de l'urgence cardiovasculaire. Les mêmes résultats ont été retrouvés aux États-Unis et à Brazzaville en 2012. Monsieur le Président, chers membres du jury, chers auditoires, la prévalence des urgences cardiovasculaires dans notre étude était de 27,5. Les urgences cardiovasculaires les plus fréquemment retrouvées étaient l'accident vasculo-cérébral, la poussée hypertensive et l'insuffisance cardiaque. Les facteurs indépendamment associés à la survenue des urgences cardiovasculaires dans notre étude étaient l'âge et l'antécédent personnel d'hypertension artérielle. d'où la nécessité d'adopter un programme national de prévention. Ensuite, de sensibiliser tous les patients qui ont un antécédent de maladie cardiovasculaire sur la nécessité de consulter très tôt en cas de problème. Et enfin, d'augmenter la surveillance des personnes âgées. Monsieur le Président, chers membres du jury, nous ne saurions terminer sans remercier toutes ces institutions sans qui cette étude ne saurait avoir lieu. Nous vous remercions de votre attention et nous restons à votre disposition pour d'éventuelles questions.
Thank you very much, Fatimata, for that very good presentation. We will now take the last presenter. I hope you are taking notes, questions. After this, they will take all the questions that we have. Are you ready? You have the floor. Let me get your slide. Come and help me get your slide. You are the last one? This?
Good afternoon, all. My name's Sefod Sonti Babara. I'm a resident FELTEP from Tanzania. I'm going to share with you the findings on the cross-sectional community-based survey, which was done to determine the prevalence and the risk factors of hypertension among adults living in Tanga region. It was done in this year, January 2023. This will be my outline. About 1.28 billion of adults with the age between 30 and 79 years, they are estimated to have hypertension. And the majority of them, about 75%, they are found in low middle income countries. And sadly, less than half of them, they are unaware if they are hypertensive. And also, they, about 42% of them, they are not on medication. In Tanzania, it's estimated that 26% of adults with the age between 25 and 64 years, they have hypertension. And in Tanga region, there was a study which was done to determine the predictors of cardiovascular disease. It was found the hypertension prevalence of 29.7. Then now we saw that there is importance to do the to determine the determinants of hypertension, risk factors of hypertension, and to see the patterns of antihypertensive medication among this region. So we had three specific objectives. The first one was to determine the prevalence of hypertension among adults in Tanga region. The second one, we determined the risk factors, and lastly, we determined the prevalence of the patterns of antihypertensive use among these individuals. It was a cross-sectional community-based survey which we conducted in 3 districts of Tanga region. Tanga is one among the 26 administrative regions in the Tanzania country, and 3 regions were selected randomly from the Tanga region, and we used the STEPSI survey questionnaire, which is standardized to do data correction. And hypertension were measured by using the calibrated BP machine, digital BP machine, and hypertension was defined as the systolic blood pressure of greater than or equal to 140 millimeters of mercury, or diastolic blood pressure of greater than or equal to 90 millimeters of mercury. Chi-square was performed to assess the differences in distribution, and we performed the bivariate and the multivariate analysis, where a modified Poisson regression model was used to assess the relationship. And p-value of less than 0.05 was statistically considered to be significant. On the results, we enrolled 1,818 with the adults with the age of 18, and the majority of the participants were from Tanga City City Council, and men were many. The median age was 41%. The prevalence of hypertension was found to be 37.7, whereas male had substantially higher prevalences compared to women. On determining the prevalence among the risk factors, it was found that those who had on multivariate, the increase in age was associated with hypertension. That as you age, you increase in age, the risk of hypertension also increases. And being male was statistically associated with hypertension, and living in Tanga region also was associated with hypertension. Being overweight and obesity was associated with hypertension, and all of them, they were the risk factors of hypertension, whereas exercise was the protective factors for hypertension. And on assessing the patterns of antihypertensive use, then among 37.7 individuals whom we found to be hypertensive, only about 34% of them, they were aware if they are hypertensive. And among them, those who were aware if they are hypertensive, it's only about 28%, 28.4, who were on treatment. And among those 28.4% who were on treatment, it's only 68.7 who were following the proper antihypertensive medication. Our findings revealed the high prevalence as compared to the STEPSI survey, which revealed the 26%, and this can be explained as the year differences, because this is the more recent study, and a lot of changes and lifestyle changes have been happening. And male gender was risk factor for hypertension as compared to women. Of course, this because it can be explained as men, they have a weak healthcare seeking behavior habits compared to women. And the Tanga City Councils, of course, was found to be the risk factors as compared to the other councils which we enrolled the individuals, and this because of urbanicity. And the physical exercise has been shown to be a protective factor. Of course, this is shown in many studies. And obesity and overweight, they were the risk factors of hypertension. Of course, they are very known that if you are obese, then you are more likely to be inactive. In conclusion, we observed the very high prevalence of hypertension. And overweight, being male, and living in Tanga, and having the age above 45, they were the main risk factors for hypertension. And doing physical exercise was found to be protective for hypertension. The majority of individuals in the community, they were not aware if they are hypertensive, and very few, they were on the proper medication. In the recommendation, we recommended to the Minister of Health that they should strengthen health education on risk factors of hypertension and the importance of screening, especially in the young age, as we saw that the age of 45 was the risk factors. And also the healthcare workers to emphasize that those patients who are found to be hypertensive, they should adhere to proper antihypertensive medication. And also to the member of community, this calls for everyone to do physical exercises. Then this is my reference. I would like to acknowledge the Minister of Health of Tanzania and the Muhimbili University of Health and Allied Sciences for the logistics and the supervision of this work, and the USAID, CDC, PEPFAR for the funding of this study. Now, I would like to welcome you to Tanzania, the home of hospitality in the Mount Kilimanjaro. Thank you.
Thank you very much. I think we have listened to 4 very interesting presentations, and this session is very gender balanced. We have 2 male and 2 female presenters, and the topics were hypertension. I think 2 people presented on hypertension, 1 on cancer, and the other one on cardiovascular emergencies. 4 very interesting presentations. But I observed that many of you were sleeping or you are glued to your phones. So maybe you have to prove me wrong by how active or participatory you'll be in the Q&A session. So thank you very much. So now we'll open the floor for questioning. We have 4 presenters. And please, I want you to make your question sharp, very short, to the point. Leave the introduction around. Come to the point because we are far behind schedule. Okay? We'll take 2 rounds of questioning, maybe 5 at first. We take 5 questions. And please introduce yourself and then tell us the addressee of your question so that it's easy for them to answer. Is that okay? All right, so open the floor. Can someone help me pass the mic around? All right, Dr. Adel, you have the floor. The presenters, please take note. If the question is directed to you, please take note.
Thank you so much, Dr. Vandi. My name is Dr. Adil Douma from Sierra Leone Field Epidemiology Training Program. So my question to the presenter from Kenya. So you have mentioned that in your method you use Bayesian regression. So can you clarify on that one? And also if you have any ethical clearance for your study. The second question goes to Fatima. You said that your outcome variable is cardiovascular. So you said your outcome variable is cardiovascular emergency. So also, can you clarify how you define your outcome variable? Then also, if you have also, because you have mentioned that you use consent form, but have you received any ethical clearance for your study? Then the last question goes to the CFORT. I don't know if I say the name correct. So I noticed that in your result, also in your method, you also indicated that you use Bayesian regression. So also you can clarify on that point. And also you said that male is associated with hypertension. But I noticed that the risk ratio, the odd ratio or the prevalence ratio is 1.06. So can you also clarify on that point? Thank you.
All right, thank you, Dr. Adel. Any more questions? Yes, who has the mic? Can someone help me pass the mic?
Dr. Atem from South Sudan. My question goes to the presenter from Niger. I missed to take his name. My question is there any association between uranium extraction and cancer in Niger? And if so, why is cancer more prevalent in female than men?
Noted. Next question. Yep.
Ok, merci. C'est Michel, en provenance de République démocratique du Congo. J'ai 2 questions. La première s'adresse à la présentatrice de Kenya, de Mombasa. En fait, ici, je voulais juste savoir la motivation, ce qui l'a vraiment motivé à pouvoir réaliser cette étude, étant donné que, et c'est vrai, c'était une étude transversale, et il a fini par donner pratiquement des facteurs associés. Bien sûr, l'hypertension chez les personnes qui sont sous traitement ARV. Et ces facteurs sont les mêmes qu'on retrouve aux personnes qui ne prennent pas les antirétroviraux, qui n'ont pas le VIH. Et donc nous voulons savoir quelle était vraiment sa motivation pour arriver à produire cette étude. À part ça, il y a le dernier, c'était CEFOR. Alors pour CEFOR, j'ai vu qu'il a proposé dans les recommandations l'éducation de la population, surtout les jeunes. Mais aussi il a stigmatisé dans la discussion le fait que les habitants de Tanga avaient une prévalence élevée, si j'ai bien compris. Et est-ce qu'il n'y a pas d'autres mesures, selon les nouvelles approches, qui pourraient nous amener à inverser cette tendance? Déjà, si ces personnes qui vivent à Tanga sont des personnes nantis, on suppose qu'ils ont des moyens, ils sont peut-être suffisamment instruits pour connaître qu'ils doivent consulter les plus tôt. Est-ce qu'il n'y a pas de nouvelles approches que vous pouvez proposer?
Merci beaucoup. Je voudrais aussi à mon tour féliciter tous les présentateurs pour leur brillante présentation. Le premier commentaire va à l'endroit du collègue qui a présenté sur les cancers. On a vu que la prévalence qu'il a eu à présenter va décrescendo quand on quitte la capitale vers les autres régions. Et je trouve que ça a été une très bonne initiative de mettre en place un deuxième laboratoire, peut-être pour le rapprocher des autres régions, parce que la faible prévalence là-bas n'est pas due au fait qu'en population, il y a une très faible prévalence, mais c'est parce que les moyens de diagnostic ne leur sont pas accessibles. Merci beaucoup pour cette présentation. Le deuxième commentaire, c'est par rapport à notre ami qui a présenté sur de Tanzanie, où il a trouvé que la population de Tanga, vivre dans Tanga serait aussi un facteur associé à la survenue de l'hypertension. Donc je voudrais lui suggérer de regarder ça encore de plus près et peut-être de stratifier. Surtout qu'il a trouvé que faire l'exercice physique était aussi un facteur protecteur. Donc le stratifier par rapport à dans Tanga, ceux qui font l'exercice physique et ceux qui ne le font pas. Ils pourraient trouver peut-être un modificateur d'effet. Sinon, c'est un peu stigmatisant comme on l'a dit. C'est vrai, vivre en zone urbaine peut être un facteur de risque, mais il y a d'autres paramètres qui peuvent influencer la survenue de l'hypertension artérielle. Et pour la sœur qui a présenté sur les urgences cardiovasculaires, je voudrais aussi une fois encore la féliciter. Et je voudrais lui suggérer peut-être nous parler encore beaucoup plus des mesures à prendre pour réduire la survenue et la sévérité des lésions des urgences cardiovasculaires. Merci beaucoup.
Okay. Any more hands?
D'accord, merci. Je suis Kafando Lassane, je viens du Burkina Faso. Et pour ce qui concerne l'analyse des données du registre national, je pense que quelqu'un est revenu là-dessus. Et quand on regarde un peu avec le temps, vous allez constater que de plus en plus on diagnostique les cas. Est-ce que les moyens, l'amélioration des moyens diagnostiques aussi n'explique pas en partie le fait qu'on arrive à détecter plus les cas? Il dit que vers la fin, que les cancers restent sous-notifiés. Voilà. Je ne vois pas d'éléments d'information dans sa présentation qui permet de tirer cette conclusion. Est-ce qu'il peut revenir là-dessus? Et pour ce qui concerne la présentation sur les facteurs des urgences cardiovasculaires, voilà. Et à ce niveau, j'ai remarqué qu'on s'est apaisanti sur le fait de l'antécédent que la personne ait une hypertension. Est-ce qu'on peut creuser pour voir est-ce que cette hypertension était suivie et contrôlée ou pas? Est-ce que c'est ceux qui ont une hypertension artérielle non contrôlée et qui ont plus de chances de faire, ou bien la malchance de faire une urgence cardiovasculaire? Donc j'aimerais qu'on puisse revenir un peu sur ces éléments-là.
Could you move away from the set? We are not hearing.
Ok, donc je disais que pour ce qui concerne les antécédents d'hypertension artérielle comme facteur de survenue, par exemple, de l'urgence cardiovasculaire? Est-ce qu'on peut regarder à l'intérieur les personnes qui présentent l'hypertension artérielle suivie, contrôlée, et ceux, par exemple, qui ne sont pas suivis ou qui sont dont leur hypertension est mal contrôlée? Ça permettrait de mieux adresser les recommandations. Merci.
Do we have more questions? Okay.
Thank you for your presentation. They were insightful. I am Mohamed Esba from Sierra Leone. So I have two questions. One for the last presenter is saying there was high risks of hypertension in Tanga to get high risks of infection, hypertension in Tanga. Did you compare with anything that you concluded in that area? Then the other question is for Faith. I was trying to look at your method, which the way you collected your, I think it's a prospective study, your method you collected your data, whether it's a semi-structured questionnaire or a structured questionnaire, it was not clear. Please, can you explain? Thank you. You say high risks, you concluded by saying high risks of hypertension in Tanga. Did you compare with anything that you concluded saying that? How did you reach that resolution? Thank you.
Okay, so it seems as if we have exhausted questions in the hall. Now we'll give opportunity to presenters to respond. Please summarize your responses. Don't go over all the presentation again. Summarize. Just limit yourself to the questions, please. Let's start with the first presenter, Amadou.
Merci beaucoup. Merci pour les questions. La première question, c'était de savoir s'il existe un lien entre l'extraction de l'uranium au Niger.
Could you stand, please? Or maybe come to the podium.
Merci beaucoup. Donc la première question, c'était de savoir s'il y a un lien entre l'extraction de l'uranium au Niger et la survenue des cancers au Niger. Je ne peux pas l'affirmer ici. Il n'existe pas encore d'études à ma connaissance. C'est vrai qu'il y a des cas qui sont notifiés dans toutes les zones. Ce qu'il faudrait dire, c'est que les zones d'exploitation de l'uranium sont très éloignées de la capitale Niamey. Pourtant, le seul centre de lutte contre le cancer est situé à Niamey. Les deux laboratoires d'Anapat sont à Niamey. Et comme vous l'avez vu dans mes résultats, à travers mes résultats, presque la moitié des cas de cancer sont notifiés dans la région de Niamey. Ça veut dire que c'est un phénomène qui mérite une étude plus minutieuse. Donc certainement que nous allons aborder cela dans le futur. La deuxième question de M. Kafando, alors, qui voulait savoir pourquoi j'avais dit en conclusion que les cas de cancer étaient sous-notifiés. Je l'ai dit parce que, si vous l'avez remarqué, presque les 50% des cas étaient notifiés dans une seule région. Pourtant, nous avons 8 régions sanitaires. Et comme je venais de le dire, le centre de santé, le centre de lutte contre le cancer, le centre national, il est situé à Niamey. Les deux laboratoires en appart sont à Niamey. Et nous l'avons constaté à travers les campagnes de dépistage. Quand les équipes sortent pour aller en région, ils ont plus de cas. Cela veut dire qu'il y a des cas, mais les gens ont des difficultés à venir en capitale pour diagnostiquer et se faire traiter. Voilà pourquoi nous pensons que les cas sont encore notifiés et qu'il faudrait faire des efforts supplémentaires pour aller vers ces cas qui ne sont pas encore découverts pour les diagnostiquer et les traiter. Merci.
Thank you very much for those responses. Could we have response from the second presenter, please?
Thank you for the questions. So my first question was on the Poisson regression, and for me to elaborate on that. So how we had categorized our variables were as binary outcomes. So whether they were on a tenofovir-based regimen, yes, and if they were not, no. And Poisson regression is the ideal logistic regression model for binary outcomes. In terms of ethical clearance, I got clearance from the university that is associated with our advanced program, that's IREC, also from the National NACOSTI, which is the National Clearance Institute for the country, and then also from the Mombasa County Department of Health. In terms of the rationale for research, so we've seen as we've had improvements in treatments for HIV patients, that these patients are actually living much longer than we used to see in previous years. And so they are becoming more subjected to the non-communicable diseases that affect the general population. In terms of prevalence, Mombasa County has been shown to be very prevalent in terms of the risk factors for hypertension, and it also has a higher prevalence of HIV compared to the rest of the country. And so these factors combined made it an ideal area for us to be able to study. And we also, the current guidelines in the country are test and treat. So all our HIV patients are actually on an ART regimen. So none of the participants that we reviewed were not on an ART regimen. And so for the last question was on the methods of data collection. So we used a questionnaire for some of the questions. We were looking at some of the variables such as age, alcohol, smoking, among others. And then for the questions where we find that most of the patients know that they are either on a first-line regimen or a second-line regimen, but they're not quite able to say which particular drugs that they're on. So some of this data we were still able to abstract from the patient files. Yes, thank you.
Thank you, Fred, for those snappy responses. Thank you. Now, Fatimata, your responses, please.
Merci beaucoup, Monsieur le Président. Merci à tous ceux qui ont posé des questions. La première question concernant les variables. Comment définir la variable dépendante? Nous avions dit la variable dépendante, c'était l'urgence cardiovasculaire. Alors, on avait préalablement listé toutes les urgences cardiovasculaires qui pouvaient arriver, que ce soit les urgences valvulaires, vasculaires, coronariennes, myocardiques, on les avait listées. Alors, lorsque une de ces urgences était présente, donc dans le codage, on mettait oui. Lorsqu'il n'y avait pas d'urgence, ça devenait non, tout simplement. Une autre question, c'était à savoir si on avait reçu l'autorisation du comité éthique. Oui, on avait une autorisation. Ça prenait du temps avant de l'obtenir, mais nous avions attendu. Et les patients également, il y avait une signature qui nous a posée chacun sur son questionnaire avant d'administrer ce dit questionnaire. La troisième question, c'était les mesures à prendre pour éviter la survenue des urgences cardiovasculaires. C'est un peu ce que nous avions dit. C'est surtout la nécessité de se faire suivre lorsqu'on a un antécédent de maladie cardiovasculaire. Parce que lorsqu'on est suivi, en général, ça évite des problèmes. Ou même les consultations fréquentes. Il y en a qui font des consultations ou des bilans annuels ou semestriellement. Ça également, ça permet d'éviter souvent ce genre de problème. Les antécédents d'hypertension artérielle, est-ce que c'était des patients suivis ou pas? Vous avez raison, ceci a besoin d'être plus creusé. Parce que nous, avec ce que nous avions fait, la différence n'était pas trop significative entre ceux qui étaient suivis et ceux qui ne l'étaient pas. C'est comme si on a ceux qui étaient bien suivis, disons 60%, les autres 40%. Pour moi, ce n'est pas très important. Mais j'admets que c'est une question qui a quand même besoin d'être plus creusée. Je pense que c'était tout ce que j'avais comme question et j'espère avoir répondu. Merci, Monsieur le Président.
Thank you, Fatimata. Thank you for this question. Sifo?
Okay. Thank you for your very nice interest in our study. The first clarification on the modified poison. Yes, modified poison is an alternative method for the log binomial model. So once it's ready to converge, then you can prefer to do a modified poison regression model. And for the one you saw, like the after adjusting on the multivariate, that the adjusted odds ratio was 1.06 with 95 confidence interval of this odds ratio between 1.02 and 1.1. And for the other question on the comparison, that's why the conclusion of Tanga was higher compared to where, of course, there were two main studies that we compared to. The one was the National STEPS survey, which was done in 2022, revealed the prevalence of 26, and the other study was the very study which I presented on the background, which was assessing the cardiovascular predictors, and it found the prevalence of 27.9, and now we did this very community-based survey, we find the prevalence of 37.7. And the other, like Tanga, it's a risk factor, so now what should we do? Okay, that's now interesting. So what I can recommend with regards to the urbanicity, majority of the participants, they are workers from offices. So now I can recommend for the employers to have this, the very rising burdens of non-communicable disease, such that you can even dedicate half an hour in a day as an employer to your employees to do physical exercises, and those can help to fight this very rising burden, because it's very, very devastating. And also, I can recommend also to do further study in this area to really find the actual factors for really that in urban, of course, people are learned and they are well off, they have money, they have all the resources. But yes, we see the lifestyle in the towns, they eat the fast foods, the processed meats, and other foods and lifestyles, drinking, which are very, very risk factors, which can cause hypertension. So initiatives should be made, although, of course, we have saw that even in rural areas, still the burden is increasing, but it's higher in urbans. Thank you.
Thank you very much. Can we please put big hand together for these presenters? Amazing, interesting topics. Thank you very much for your patience. I know we are far behind schedule. We are now about to go for lunch. But before we do so, we have two reminders. Don't forget to scan before you leave the hall at the entrances. Please don't forget to scan to access the session. It's very important for you. Number two, after lunch, we have very, very interesting presentation at the main plenary in the main hall. Please don't afford to miss that. We have 3 professors that will be presenting very interesting topics. Don't miss that. So with this,
we have 2 evaluators who are seated on my extreme left. That's Dr. Gabriel and George Akoa. I hope I pronounce your names correctly. Thank you. So presenters, so those are the ones who will be determined if you'll get an award. So smile to them. Okay, so this is a concurrent oral session, number 5, themed Public Health Emergency Preparedness Surveillance Outbreak Investigation and Response and Antimicrobial Resistance. This topic which is dear to my heart, so I'm happy to moderate this session. We have 6 presentations. I was checking if we have all the presenters. Earlier we were missing one, that is Hariso Abubakar. I don't know if you have entered the room. Still not. So he might save us time if he's not here. Okay. So we'll take the first 3 presentations in a row. Then we have a question and answer sessions before we continue with the last 3 or the last 2, which will be or the two if Abubakar is not in the room. So kindly note down your questions, because we need at least each presenter to receive at least one question. And the presentations which you'll be listening today in this session, Abubakar is supposed to present on cholera investigation from Niger. Then we have cholera outbreak investigation in Zambia by Ante, foodborne outbreak investigation at a wedding event by Timur. Then, but we will swap. There's a request, and we have agreed already among the presenters that Ante will be the first one. No, then we don't need to change, since Abubakar, who's supposed to be the first one, is not here. So we'll just follow, but we'll bring then Saya up before the questions and answers. So we'll start with Ante, followed by Timur, followed by Saya, then we'll have the questions and answer sessions. I hope by now we know the oral presentations of 10 minutes. Then we have about 5 minutes for questions and answers. Then we will then continue with cholera outbreak investigation resulting from lack of hand washing. This is coming from Cameroon by Haman. Then outbreak investigation of Salmonella typhi in Rwanda by Teta. So those are our lined up presentation. So to manage the time, as we were informed, we have cultural evening today. I was asked to remind the team now and then that the buses will start picking people from here to different hotels from 6. It's not one pickup. Let's not rush. If 6 reach, but when we are not done, which I don't think so, then they will be coming. There will be frequent pickups for you to get ready. The dress code, as it was mentioned, is Kenya national colors. That is black, red, white. It doesn't need to be a combination of all colors, any one of those. But don't say, if you don't have any of those, it's not that you are excluded to be part of the event. But if we have, then let's try to put on those colors outfit. So this I will be repeating in case there will be some colleagues coming in the room as we are proceeding. So I will request the presenters to come. I will not be calling them in between. Once Ante finish, I will just come to make sure that the next slide is on. Then the next presenter will come immediately. So this is cholera outbreak 0331. Ante, please come and take us through your presentation.
Good afternoon, everyone. My name is Ante Mtate from Zambia. My study title is Cholera Outbreak Investigation conducted in Mwansabombwe district, that is Luapura province in Zambia, January 2023. This is my outline that I will actually follow as I present. In terms of background, we know that cholera is an infectious disease, and it's a global threat to public health. For Zambia, we've been experiencing this outbreak since 1977, and we've been having these cholera outbreaks in different regions of Zambia. For the current cholera, it started when the notification was given to the district on 14th, and barely after 2 or 3 days, cases started increasing to about 15, and then the team was mobilized actually to conduct this outbreak investigation. Objectives, the first objective, the main objective was to confirm and establish the existence of the outbreak. Then the specific objectives to describe the cholera cases and the distribution. The second, positive agent of an outbreak. Then the third one is to determine the risk factors for the outbreak in the district. I applied the case control study, and all participants who were included actually met the case definition. And the study site is Mwansabombwe district in Wapra province of Zambia. Then the controls, these were the members of the same community without clinical signs and symptoms. And the minimum of 2 controls were actually linked to each case. So the case definition for suspected cases was any patient from Mwansabombwe presenting with acute watery diarrhea or rice watery diarrhea with or without vomiting and signs of dehydration. The probable case was a suspected case in which the SD bioline RDT is positive and or is epidemiologically linked to a confirmed case. Then the confirmed case was a suspected case in which Vibrio cholerae serotype 01 or 0139 was isolated in store. The sample size, we used the complete enumeration of the line list, and we actually enrolled 22 cases and 49 controls. Then the structured questionnaire on COBOL to interview the cases and control was in place. Then variables of interest were also identified. Then in terms of a data analysis, I did the descriptive analysis first and used the chi-square or Fisher's exact test to explore the risk factors. Then multiple logistic regression analysis was conducted, and the results were presented using median and interquartile range, odds ratio at 95% confidence interval. The results, this is the summary of results, and you note that the results were not significant. However, you will note high odds ratio in the results, as you will see. So this is table 1 for demographic and risk factors. This indicates that we interviewed about 69% of controls and 31% cases. Then the median age for the cases was 31, and for the controls was 32. Then we've seen that females accounted for 59% of cases and 53% of controls. Table 1 continues, and we've seen that 31.8% of cases had reached primary education, that is in terms of education. Then the majority of these cases were coming from a location called Tishishila village. Then in terms of occupation, mainly about 54.5% were farmers. Then when we look at some of the risk factors, we've seen that 63.6% of cases reported a member of the household with diarrhea. Then few of the cases reported with chronic diseases such as hypertension, cervical cancer, and asthma. Then the main water source for the cases and also the controls was a public bore, and about 81.8% had access to this water source. Then in terms of pit latrines, 90% of the cases had pit latrines without slab, and 13% share toilet, meaning they had no toilet but they share with the other households. This is a graph, figure 1, indicating the proportion of signs and symptoms of cholera, and we've seen that the main symptoms presented by these cases was actually diarrhea, vomiting, and also leg cramp, and some dehydration. Then this is an epidemiological curve showing a propagated a picture of onset of symptoms for the cases from 12th to 29th January 2023. Then in terms of laboratory results, we've seen that 5 stool samples were collected for confirmation, and out of these, 2 samples had Vibrio cholerae, organism isolated. And also a sensitivity test was actually conducted. So table 2 as logistic regression model risk factors results, and we've seen that age is a factor, especially being 66 and above, and also education, especially being in primary or no education. And we've also seen that taking care of a patient, using piped water, then storing water in an open bucket, and having a pit latrine without a slab, and also sharing a toilet with other households. Though the p-values are not significant, but of course the adjusted odds ratios were high in these factors. So in conclusion, we are saying bacteriological examination of the 2 samples revealed Vibrio cholerae as a causative organism, and of the 22 cases, the median age was 31, and the female were the most affected. Then majority of cases were coming from Tishila village, and we've seen that being age 65 and above, not being to school, drinking piped water, taking care of patients is one of the factors that may have contributed to the outbreak in the district. Limitations, missing details of the line list, especially address and the landmark. Then public health intervention during the outbreak, case management, contact tracing, active case search, distribution of liquid chlorine, and we also conducted risk communication and community engagement. Then in recommendations, we recommended that we intensify risk communication and community engagement, and also practice good hygiene. Then the community should also be called on board to have good toilets, and also to treat water, and also to keep water in containers which are watertight. These are my acknowledgements and my references. Asante sana, thank you.
Good afternoon. Let me present our theme, foodborne outbreak investigation on a wedding event, Batken, Kyrgyzstan 2022. My name is Timur Dautov. I am from Kyrgyz Republic. On August 2nd, 2022, local health departments were informed that over 100 people had sought care of reported gastrointestinal illness of unknown etiology. This was an unexpected surge in cases, and we anticipate an outbreak had occurred. We wondered what was the common link. Were there other cases? When medical help was not sought, were there any asymptomatic cases? Was transmission still occurring? A team of FETP residents, including myself and graduates, were assigned to conduct an outbreak investigation. The picture here shows the hospital where cases were reported. To provide the setting, let me tell you a bit about my country, Kyrgyzstan, officially called Kyrgyz Republic. It's a landlocked country in Central Asia with a lower than average income. It borders Kazakhstan, Uzbekistan, Tajikistan, and China, as shown on this map. Bishkek is the capital and largest city of the country. The outbreak occurred in Kadamjay city, which is located in Kadamjay district of Batken region. This is the very southwest corner of Kyrgyzstan. The city has a population of 14,000 in 2021. In Kyrgyzstan, prevalence of food insecurity is high in rural areas, and food insecurity is higher in Batken region. To identify common risks and find cases, we interviewed patients using a structured electronic questionnaire programmed in COBA toolbox. We analyzed data using R. This image shows an FTP graduate conducting interviews. Quickly at the start of the investigation, we learned that all ill persons had attended the same wedding on July 30th. Weddings in Kyrgyzstan are often very large. People come from far away, and food is an important part of the wedding event. With the report defined cases as people who were acutely ill attending the wedding event, and with the signs and symptoms of diarrhea, fever, vomiting, and weakness. We got a list of all attendees and their contact information, and learned that 250 people had attended the wedding. We were able to contact and get consent for interview from 201 participants, or 80% attendee. Most of the people who couldn't conduct it left Kyrgyzstan or the region, or their contact information could not be found. From 201 interviews, 110 had been sick and got medical assistance. Cases peaked on the morning after the wedding event, within 6 to 24 hours of food consumption. 48% of people who got sick were 60 years or older, and this proportion was not statistically significant from those who didn't get sick, based on chi-square testing. 80% of people who got sick were female, and this proportion was statistically significant from those who did not get sick. Symptoms were consistent with foodborne illness. 96% had fatigue, 95% had diarrhea and abdominal pain, and 84% had fever. The most commonly eaten food was Kazakh meat, which contained different types of boiled meat. Salad abzhorka had the highest attack rate. 76% of people who ate it got sick. Salad abzhorka contained different meats and mayonnaise. Also, 84% of people who ate Caesar salad got sick. Caesar salad contained chicken, mayonnaise, and eggs. Attack rate was 66% among people who ate any chicken. 95% who got sick, and 60% of people who didn't. In multivariable modeling, salad abzhorka, which contained meat and chicken, Kazakh meat, and Caesar salad, which contained chicken and eggs, were associated with the increased odds of illness. Patients were not tested, but we were able to collect and test 32 food samples. Pathogens were detected in 3 food types: Kazakh meat, chicken, and Caesar salad. Proteus vulgaris was found in all 3 samples. It's normally found in a human and animal intestinal tracts and not usually associated with foodborne outbreaks. Escherichia coli is associated with outbreaks, but symptoms onset is usually 2 to 5 days after food consumption, and therefore not consistent with this outbreak. Klebsiella is also not typically associated with foodborne outbreaks, but outbreaks have been documented. Also, symptom onset is consistent with this outbreak. Laboratory tests were not performed for patients because of lack of laboratory specialists and insufficient equipment in the region. It's not possible to identify the cause of aging for this outbreak. Another limitation was that the investigation team arrived on day 2 after the event. Sampling at the restaurant and leftover food didn't reflect the quality of food at the time the outbreak began. Also, the investigators were not able to conduct a comprehensive inspection of the restaurant because they had completely disinfected the facility. Another limitation was that 20% of guests were not reached. The majority had left the country. Many people in Kyrgyzstan and in Batken region migrate for economic purposes. Our study demonstrates a potential link between consumption of tainted food and disease, but doesn't exclude the possibility of alternative explanation. However, several pathogens were detected in food, and there was a strong epidemiological link between specific food and diseases. We can conclude that the outbreak is mostly like foodborne. Improper food sanitation and hygiene practice likely contributed. We made recommendation to strictly observe food preparation and sanitation requirement. Also, we made recommendation for improving food safety along the food production chain. Lastly, we made recommendation to increase laboratory capacity, which will result to improve patient treatment and surveillance on foodborne disease. Pictured here is a typical wedding bride. Fortunately, nobody died. And the newlyweds are likely living with the groom parents, as is common in Kyrgyzstan. Although FETP CDC Central Asia students hadn't been invited. But I think we were the most important guest of this wedding event. Thank you. Asanta sana, Chong Rahmat.
Good afternoon. Title of my work, of our work, is Salmonellosis outbreak at a cafe, Turkestan region, Kazakhstan, October 2022. My name is Saya Gazezova. I'm from Kazakhstan. In Kazakhstan, in a city of 70,000 inhabitants, 168 people were ill after having eaten food from the same cafe. 98 people were hospitalized from October 7th to October 10th of 2022 with gastrointestinal illness. All hospitalized people had eaten food from the served served from October 4th to October 7th. Also, a location was identified. The source of their illness was unknown. Graduates and residents from the Central Asia Field Epidemiology Training Program, pictured here, and including myself, were assigned by the Ministry of Health to conduct an investigation, identify the source, and prevent further cases. We conduct the search for additional cases. We looked for reports in healthcare facilities and the health department. Our case definition was people who had eaten food from the cafe and had become ill over the following week with symptoms of fever, abdominal pain, diarrhea, nausea, or vomiting. The restaurant provided a list of all people who had eaten at the cafe. They were able to get this list because people pay electronically using an app, and that app is linked to people's names. From this list, we called everyone who had ordered from the cafe. We identified 302 people who had eaten food from the cafe. Most orders were for chicken, hamburgers, pizza, sushi, and French fries. Of these 302 people, 91% consented to be interviewed. Of the 276 participants who consented, 51% reported having gotten sick, and 49% people were controls. The most common symptoms reported by the 142 people who had become sick were diarrhea, abdominal cramps, headache, and fever. Symptoms onset was rapid. Symptoms developed from the 6 hours to 4 days after having eaten food from the cafe. Cases peaked on the 6th of October, as shown here in this histogram. By the time our investigation began on the 10th of October, cases had subsided. 56% women were cases and 45% under 18 years old. People were asked what they had eaten, and this was verified with the receipts given. Products containing chicken had been eaten by 99% of sick people and by 34% of people who did not get sick. The attack rate for the 185 people who ate chicken was 76%. In multivariable analysis, where we controlled for consumption of other foods, people who ate chicken wings had 324 times the odds of having been ill. To identify potential source pathogen, we were able to obtain stool and gastric lavage samples from 98 sick people that had been hospitalized. Among sick people tested, 9% had Staphylococcus aureus detected in gastric lavage samples. And Salmonella enteritis was isolated in stool samples from 22% of sick people tested. Also, we were able to collect samples of different food products served in the restaurant, and in testing, Salmonella enteritis was also isolated from chicken and raw horse meat. Onset time of 6 hours to 4 days is more consistent with Salmonella enteritis than with Staphylococcus aureus. The top 3 reported symptoms were also more consistent with Salmonella. Also, studies show that about 25% of people have staph colonization in their skin and nose. So it's not surprising that it could have been detected in samples. Additionally, Salmonella was detected in both chicken and patient samples. Staph aureus was only detected in patient samples. Unfortunately, our investigation is limited by the inability to directly link chicken to patient strains. Sequencing is not available in Kazakhstan and is not used in foodborne outbreak investigations. Also, we were unable to identify meat suppliers to determine the source of the pathogen. Because purchases are made from different suppliers without official documents. All persons with any food from this cafe were advised to discard them by news and publications on social media. Persons were advised to seek care if they developed any symptoms. Recommendations made to comply with food safety measures, including routinely assess the risk of contamination of raw materials and ready meals with infectious disease pathogens, and also compliance with storage requirements, temperature regime, and use only certified products. We are happy to inform that nobody died, and also the outbreak was not the end of business for the restaurant. And we heard that they came up with a secret chicken recipe, and that became very popular, and they're still cooking their crispy chickens and delighting their guests. Thank you. Asante sana.
We have listened to the three presenters. So it's now time for discussions and questions. Any clarification from the presenters? If we can be precise in asking our questions, of course, starting introducing yourself. Can I see two hands? Yes, Doc. Anyone who need translations? Because I know translators could not pick that up because there was no use of the mic. Seems you do. Okay, sorry. If you can take the mic and repeat the question for the sake of the colleagues.
Okay, thank you. So I say thank you for the presentation. It's very excellent presentation. I have similar question for the presentation from Kazakhstan. I was asking what type of public health actions did you actually take to stop the two outbreaks? If you have taken any public health action or any intervention to stop the two outbreaks. Thank you so much.
Okay, you can take we can take about 3-4 questions, then they give chance to presenters to respond in a row.
Yeah, thank you very much for a good presentation. I have one question for the first presenter, if I am correctly called it, Anle, who presented cholera outbreak investigation, case control study. I just want to know, maybe as we all know, cholera is most of the time it is asymptomatic. How you really identify your controls? How much you are confident that controls are really a control? Because in cholera outbreak, most of the time, many people might be affected, but they remain asymptomatic. So how did you really identify the controls, and how much you are confident enough that they are really a control? Thank you.
Thank you. There is one hand that
good evening. My name is Eunice Omondi. Thank you very much for the nice presentation gearing towards food safety. For the the presentation regarding cholera. It's something which also was presented somewhere, and my keen interest is our colleague expounding on the issues of drug susceptibility, because it really got out of way at some point, and there were issues of antimicrobial resistance. So could you please elaborate on the strain of the pathogen which was really causing some havoc regarding cholera? And then for the Salmonellosis outbreak in Kazakhstan or something, yeah. Would you please also explain something to do with the antimicrobial interventions, given that we have a silent pandemic known as the antimicrobial resistance? Yeah, thank you.
Thank you. Let's take the last question. Don't you have a mic there? Okay, that will be our last session, the last questions. Then we'll give presenters a chance to respond.
Okay, thank you for the opportunity. I like the Kazakhstan, their presentation was pictorial, which was very nice. But I was wondering, once it was an outbreak, I wanted to see some epic curve to see how it started and how it peaked. Maybe probably you can share some highlights on how it progressed, since you were not able to, the samples that you took, it took about 2 days and you did not even get the food sample. So I want to find out how did it start and how did it ended. Thank you.
Which presenter specifically? For both of them? Okay. Just as the first question, this applies to both of you. Okay, we hand over now to our presenters. I'll ask them in the order they have presented. Ante, if you can take, maybe you can just stand and come to this mic here. Then you respond to your questions.
Thank you so much for the questions. I think the first one has to do with the controls, how we identified the controls, and also bear in mind that cholera is asymptomatic at some point. Yep. So for the controls, we looked at those who are not actually showing signs and symptoms, and of course they were coming from the same community, and it's actually very difficult actually to identify whether someone has the virus or the bacteria if you haven't done the tests. But again, you can't do a test to somebody who is actually okay, who is not showing any signs and symptoms. I agree with you on that one, but in our study, that's how we actually identify them. We looked at the clinical presentation. If they are not showing those signs, they were considered as actually controls. Yes. And for the strain, it was Ogawa, that is the 01, that was the strain. Thank you.
Thank you very much. Thank you. I am from Kyrgyzstan, Central Asia, FETP disease resident, not from Kazakhstan. It's important. I'm sorry. I would like to answer in Russian because it will be easier for me. Yep. Thank you. Был очень хороший вопрос по поводу того, какие мероприятия были приняты после того, как прошла вспышка, и что мы сделали, чтобы такого в дальнейшем не появлялось. Это действительно очень хороший вопрос. Мы не стали изменять основную большую систему общественного здравоохранения, но у нас, как я уже говорил в своей презентации, у нас были проблемы по лабораторному тестированию именно людей. Мы могли бактериологические исследования проводить для пищевых продуктов, но клинические исследования для населения было очень слабое. В настоящем, после этой вспышки, Кадамчайский центр Госsanэпидемнадзора покупает лабораторное оборудование для того, чтобы таких вспышек не было. И еще самое главное, мы им сделали очень большую рекомендацию по поводу мониторинга пищевой промышленности, то есть транспортировки, хранения и производства пищевых продуктов. Это было основным, самым важным моментом. И, да, извините, I'm sorry.
Thank you for the question. The public health activities were very important in this outbreak. As he was showing in this presentation, one of the limitations were lack of laboratory capacity in the clinical prospect. So the recommendation to the system was to strengthen public health labs for testing the patients, because as of time of this outbreak, the testing was in the public health laboratories was done mainly for food products in the restaurants and stores. It's strengthened now, so they do test patients. And the second recommendation that was provided and implemented later, stringent monitoring of the food chain supply to the restaurants, to supply and storage, actually, conditions, how it's stored and prepared in the restaurants. The monitoring from one stage to the other, so that the safe food is provided to the table of people.
Да, и еще второй вопрос. Большое спасибо своему коллеге. Thank you very much. И здесь эта эпидкривая, это тот день мы указали в начале. Let me. Cases peaked on the morning after the wedding event. July 30th was a wedding event, and within the 6 to 24 hours after food consumption. And investigation started. It's one of the hour limitation when investigation starts. Я ответил на его вопрос.
So did he answer your questions? Here is the epicurus, yes. So from the start of the outbreak, July 30th, until the time when we started actual investigation.
Спасибо.
Спасибо большое за вопрос. На первый вопрос я бы хотела ответить, что мы предприняли, чтобы предотвратить будущие случаи вспышек. Мы для этого на данном уровне по политике нашей страны, вообще Министерства здравоохранения, мы начали активно просвещать вообще данные по профилактике пищевых вспышек, как их не допустить, мы активно просвещаем их в социальных сетях. Делаются публикации разных статей на сайтах, на официальных сайтах министерства, а также всех медицинских учреждений. Также в социальных сетях, как Instagram, Facebook и так далее. Также по политике нашей страны у нас есть... Или вы перейдете? Первый.
One of the activities that was conducted, the foodborne outbreaks are very often in the country. The recommendation was to start advising, to provide info on these outbreaks on social media. the ministries, the National Center of Public Health actually publish every report on foodborne outbreaks, the symptoms, where it happened, how it happened, so that people know how to be prepared just for the general population, but also for the sector, private sector who owns this business, so that they provide food safe for people. Еще дальше.
Также по политике нашей страны у нас есть для развития малого и среднего бизнеса у нас есть запрет на, то есть мораторий на запрет на проведение проверок каких-либо внеплановых. Из-за этого мы не можем как бы активно проводить работы для предотвращения вспышек, но получается, проверки у нас в стране только проводятся, если происходят вспышки какие-либо. Ага. У нас также активно проводится работа с областными департаментами, с управлениями. Именно проводится работа для расширения лабораторной диагностики, чтобы расширить. Мы в начале года у нас планируется как бы план на дальнейший год, на предстоящий год, и у нас формируют как бы заказ на определенные лабораторные тестирования. Из-за участившихся пищевых вспышек на данный момент проводится работа по расширению лабораторного тестирования. Нет, еще продолжается до сих пор.
So one of the biggest limitations is from Kazakhstan. In Kazakhstan, the limitation for the sector, for the Department of Health, is like they're restricted to do inspections and monitorings of restaurants, of schools, just for the inspection of the food safety, unless the outbreak happens. If the outbreak happens, then they start investigation. That's why we try to post as much possible information on that. And still, it's under the president to approve this stuff. The other thing that was very important is laboratory capacity. It's lacked laboratory capacity for testing food pathogens in the clinical sector. That was expanded after that. The outbreaks happened this year so often that the ministry is investing and widening the list of pathogens that is allowed to be tested through the government sector.
Также хотела добавить, что я вообще работаю в Национальном центре общественного здравоохранения. Также нами же эпидемиологами проведены обучение среди районных и областных специалистов, кто именно работает с пищевыми вспышками на районных и областных уровнях.
And our resident is working in the National Center of Public Health. So they do trainings for epidemiologists on local level, how to conduct foodborne outbreak investigations, prevent them earlier. And for the laboratory specialists, how to test actually the for specific pathogens.
Да. И касательно второго вопроса, получается, у нас лица употребляли в кафе, вообще кафе она работала на доставку и употребляли еду в самом кафе. Получается, лица употребляли с 3 по 7 числа октября, и затем первые случаи у нас были 5, и как вы видите, 6 числа, 6 октября у нас было наибольшее количество заболевших, но одно также из как бы ограничения, мы начали очень поздно наше расследование, только на 10 число. Но так как я работаю на республиканском уровне, до нас информация доходит чуть позже, и с подписанием документов это все у нас происходит немного позже.
So the curve is presented here. The outbreak happened in the cafe which delivers food, and the food was distributed from the 3rd to 7th of October. But the highest number of cases was on the 6th, and investigation is also started later. The outbreak happened in a small remote area, and she's working in the national level. Like they heard about outbreak with after certain time. That's why it's a bit late. One of the limitations of the study. Thank you.
Now there, round of applause for our presenters for attending to the post questions. Inviting the next presenters, starting with Haman, who will be presenting on cholera outbreak resulting from lack of hand washing in Cameroon, and he will be followed by Teta. Okay, let's be prepared during the questions and answer questions, because Haman will also respond in French. So let's make sure that we have some translation devices nearby us. Again, just to remind ourselves on the event tonight, the pickup to the respective hotels will start at 6. The colors, the theme is the national color, Kenyan national colors: black, red, green, white. Is white on? Okay. Any of those colors. It does not need to be all of them. So, okay. I'm going to open this to have your.
Good afternoon, everyone. I am Dr. Abdul Wahab. I am medical doctor and field epidemiologist. It is a pleasure to me to present you the finding of our work done in Pitoa, which is located in the north region of Cameroon. The following outline will guide us throughout our presentation. As we know, cholera is an acute diarrhea disease that can kill within hours if left untreated. It is estimated that there are between 1.3 to 4 million of cholera cases each year in the world. According to WHO, cholera epidemics in Cameroon are occurring closer together every year, and the number of cases reported during an outbreak is rapidly increasing. Since 2018, Cameroon has been experiencing a resurgence of cholera epidemics. In fact, in October 2021, a cholera epidemic started within 3 regions of Cameroon, particularly in the central region, southwest region, and littoral region. Within a period of 7 months, the Ministry of Health recorded about 8,000 cases and 148 deaths. This slide shows the cholera. This slide shows the epidemic curve of cholera in the north region in May 2022. On the 18th of February 2022, a cholera confirmed case was recorded in the Badingo Health area located in the Pitoa Health district by the Centre Pasteur du Cameroon. And since the beginning of this epidemic, only the Pitoa Health district has recorded cases in the north region. Given the sporadic notification of cases in the Pitoa Health district since February 2022, coupled to the fact that the district was identified as a potential cholera hotspot, the Ministry of Health ordered an in-depth outbreak investigation. The specific objectives were to describe the epidemic, to identify the risk factor of the disease, and to reinforce prevention and control measures within the community. Therefore, we carried out a matched case control study in the Pitoa Health district during 1 week in June 2022. Case definitions were adapted from the Integrated Disease Surveillance and Response Technical Guide. suspect case was then referred as any individual presenting with an acute watery diarrhea without vomiting residing in the Pitoa Health District during the period between the 1st February to the 8th of June 2022, and was considered as a confirmed case. Any individual from whom Vibrio cholerae 01 or 0139 was isolated in the stool by culture, or any suspected case with an epidemiological link to a confirmed case. For the analytical part, any individual meeting the definition of confirmed case was considered as a case, and any person residing in the same household or in the neighboring household within 5 blocks of a cases and not meeting the case definition was registered as a control. So we included in our case control study all the patients from the adjusted line list of the district found during the descent of the team, and we choose 2 controls for each case. After the briefing with the district executive team, we visited the health facility in the affected areas and reviewed the register using the case definition in addition to the line list. We then carried out an active case finding in the community and updated the district line list by adding the case missed by the surveillance system. After getting informed consent, we interviewed all the cases found and their respective control. We therefore gather sociodemographic data, clinical condition, and previously reported suspected risk factors. Collected data was then analyzed using EBM SPSS software. We generate graph using Microsoft Excel and the map using QGIS. Logistic regression was used to search for cholera risk factors. Variables associated with a p-value less than 0.2 in bivariate analysis were there entered in the same logistic regression model. The difference was considered significant if the p-value was less than 0.05. Prior to the study, we obtained the necessary administrative authorization, and the data was collected and analyzed in the strict confidentiality. These slides show the cholera case inclusion process. So, following the review of the register, 216 suspected cases were identified. 8 of them were confirmed by epidemiological link, bringing the total of number to 38. 13 cases were identified during the active case finding. And finally, we had 51 cases. Of these 51, 40 cases were found, 4 forms were incomplete, and 36 cases were included in the analytical parts. This slide shows the evolution of the case and death in the Pitoa Health District from February to June 2022. Follow the bell-shaped curve with a peak in the 16 epidemiological weeks. The overall description on this map shows the distribution of cases in red star within the 5 affected yellow sheep health areas of the Pitoa Health District. We can also appreciate water point location in blue dots, and the red cross inside circle represent the health facility used as cholera treatment centers. Around 45% of the district cases were found in the Bula Ibi health area, which is in the top right. In our study, the population age varied from 5 months to 18 years, with a median age of 7 years. The female to male sex ratio was 1.9. Half of the patients with cholera had moderate dehydration. For the 36 cases finally included in our study, we matched 72 control. 54% of the study population were female, while the majority were school infants of less than 5 years old. Concerning the search for the risk factors, in bivariate analysis, only 2 variables were significant. These include not having latrine at home and not washing hands with soap. But after logistic regression, only failure to hand wash with soap was associated with the cholera in Pitoa Health District, with an adjusted odd ratio of 2.9. Based on this finding, several public health actions were taken in response to this epidemic, including isolation and treatment of all the cases, demonstration of hand washing in the community, and capacity building on cholera for healthcare workers and community healthcare workers. In conclusion, 51 cases and 4 deaths were recorded in half of the health area of Pitoa Health District during this outbreak. Female and under 5 years children were the most affected. And not washing hands with soap increased the risk factors of cholera by almost 3 times. In addition to the action highlighted above, we strongly recommend to the district medical officer to hold an advocacy meeting with the local authorities to encourage community involvement in the fight against cholera, and to the P2A Council to distribute soap to households in the affected community. These were our reference. And finally, we say thank you to all the staff of the Ministry of Public Health involved in the fight against cholera. We express our gratitude to the CAFE-TP supervisors for their effort, and we also acknowledge our various partners, USCDC and DITRA. Thank you.
We welcome on podium our next presenter.
Good afternoon, ladies and gentlemen. My name is Isabelle Teta Batanadje. I'm from AFETP Rwanda. I'm going to present an outbreak investigation that we conducted. It's an outbreak investigation of Salmonella typhi in the southern province of Rwanda. This is a descriptive study that was conducted in November 2021. As introduction, in November 2021, the Rwanda Biomedical Center, which is equal to the Public Health Institute in Rwanda, received an alert of an unknown illness. And that alert had caused an increase of patients in a health center called Shimba in the southern province of Rwanda. Some of the common symptoms that patients were experiencing were fever, severe headache, body weakness, abdominal pain, diarrhea, and vomiting. Following that, a team composed of 4 field epidemiology training program residents and 2 Rwanda Biomedical Center staff were deployed to investigate the outbreak. Some of the objective of the outbreak was to identify what was the cause of the illness, to conduct a descriptive analysis of the cases, and also to establish preventive and control measures at the site. Here are the methods that were used. It was a descriptive method that was used. We developed a case definition of a suspect case. The case definition was any patient that consulted the health center from the 1st October 2021, and they presented at least 3 of the mentioned symptoms above before. From that case definition, a line list was developed of suspect case, and a total of 171 suspect cases were recorded. We developed a questionnaire using AP-Info. Also, we conducted environmental assessments in patients' households, and we conducted interview. Environmental assessment was assessing the drinking water that was used in the household, if they was using treated water, or the latrine that they had, and also the source of water that they use. sample of new patients that new patient that occurred during the investigation was also collected and sent to the laboratory. As I mentioned, it was a descriptive analysis in terms of person, place, and time of data collected. Ladies and gentlemen, this is the result that was from the study. As I mentioned, it was 171 patients that we found in the records, but we could only reach 129 patients because some were not available at the moment, and others we didn't have their consent to assess and investigate and interview them. As you can see here on the AP curve of cases, we managed to find the index case, which was on the 30th September, and the peak here was on the 22nd October of 2001, and we conducted the investigation one day after the alert was notified, which was on the November 24th, 2021. This is the distribution of the suspect cases by age group. The age group 5 to 14 years old had the highest cases, which was 36 cases. Moving to the distribution by person, we had the high number of female, which was 53%. In occupation, students had the high number, which was 43%. And in terms of residence, the village of Rugarama had 90% of the patients that were recorded. This is the distribution by the clinical features of the patients. Most of the patients experienced fever, body weakness, abdominal pain, headache, and fever, body weakness, abdominal pain, and headache. These are the 4 main symptoms that were patient experienced. In the environmental assessment that was done in household, as mentioned, we investigated on the type of the source of water that was used. 67% used spring water, which is water from underground, and 46% uses public tap water, and among them, 13% only treat their water before drinking it. We also assessed the latrines, which was pit latrines. It's in a rural area. 91% had latrines, but 31% of them had a good hygiene. So in the interviews that were done while investigating in the household, the key finding that was found here is that the village resident reported that there was a water collection tank that supplied the public tap water that were used by the village residents. So that water tank collection was cleaned one day before the investigation. Yes, the investigation was started being conducted. There were no known food or drinks exposure that was linked to that illness. In the laboratory results, during the investigation, there were 17 samples that were taken, and among the 17 samples that were taken, 13 were from blood specimen reviewed. 2 of them reviewed that they had Salmonella typhi. Concluding, based on the clinical signs, the laboratory results, the environmental assessment, and interview that was done, we concluded that the outbreak was from Salmonella typhi, which causes typhoid fever disease. Typhoid fever disease is a disease that spreads through the consumption of contaminated food or drink. So, and the possible exposure of, in this study, was the contaminated water collection tank. We recommended, after the investigation, to conduct proper water chlorination and filtration of the water collection tank, and also to improve the wash measures through awareness campaigns, especially in Rugarama village and also neighboring villages. As also part of public health action that was conducted, these findings were shared to the district, and through the district leadership, there was a regular water chlorination that is being done, and also the awareness campaign are also done, not only in the Rugama village, but the whole sector of Simbi. Thank you so much.
A clap from one hand. Let's give a round of applause to both presenters. But before I invite for the questions, I'll ask for the last time if Harriso have entered this room, who's supposed to be the first presenter in this session. Seems not. Thank you for saving us time. So I then open the floor for the audience to get clarity from these vibrant presentations. I'm seeing one hand. Okay, go ahead, Monica.
Good afternoon. My name is Monica from Namibia. Oh. Good afternoon, colleagues. My name is Monica from Namibia. Thank you, presenters, for the wonderful outbreak investigations. I have two questions, one for each of our presenters. The first presenter, I think you mentioned in the results that I didn't get it well, but it had to do with hand washing, the only one that was significant in the multivariate. You can correct me on that. And then you also found that it was mostly women and children that were affected. My question is there perhaps a reason why women and children were most affected, relating now to the variable that is significant? The second question I have is for presenter number 2. I wanted to ask, I actually have two questions for you. The first one is there perhaps any insight of the burden of Salmonella typhi, or rather typhoid, in Rwanda? You didn't give us any background. And then the second one is on the case definition. Is there perhaps a reason why you restricted the case definition, or rather the case search, to only people who reported to the hospital and not in the community, just in case there was someone sick in the community and they never reported to the hospital? I thank you.
Thank you for the questions. Do we have other questions? Thank you. Monica, give the mic behind you.
Ok, merci. Bonjour à tout le monde. Bonjour à tous les présentateurs. Ma question s'adresse à la deuxième présentation. Alors, il s'agissait bien sûr d'une épidémie de fièvre typhoïde, mais je ne sais pas qu'est-ce qui a été fait. Est-ce que ces patients ont été traités et quels sont leurs devenirs? Merci.
Thank you. Since both presenters have received the questions, we welcome them back on the podium, starting with Yaman. As I indicated earlier, he indicated that he will be responding to his question in French. So if you can take our translation devices so that we hear what he will be, how he will be responding to that question. Thank you.
Ok, merci beaucoup pour cette question. Donc, effectivement, c'est le non-lavage des mains avec du savon qui a été identifié comme un facteur de risque de choléra dans le district de santé de Pitois et non le non-lavage des mains tout court. Donc, c'est le fait de ne pas utiliser du savon lors du lavage des mains qui exposait encore plus les patients, les personnes à développer le choléra environ 3 fois plus. Donc, pourquoi les femmes et les enfants? Donc, comme nous l'avons dit, choléra, Pitois, le district de santé de Pitois est dans la région septentrionale du pays. Et dans cette région, culturellement parlant, après avoir fait les selles, on se lave directement avec de l'eau. Mais étant donné que c'est un district de santé qui est rural, le niveau de vie est extrêmement bas. Donc du coup, avoir du savon dans ces ménages-là est vraiment très difficile. De ce fait, à chaque fois que certaines personnes de la communauté vont à la selle, ils se lavaient simplement avec de l'eau sans utiliser du savon. Et pourquoi maintenant les femmes? Et dans ces communautés-là, c'est beaucoup plus les femmes qui s'occupent des enfants. Les hommes ne s'occupent pas des enfants. Donc du coup, si un enfant va à la selle, c'est à la maman que revient la charge de nettoyer l'enfant. Et donc si on a une personne qui est contaminée, donc ça augmente encore plus la contamination chez le sexe féminin et les enfants. De plus, on a pour habitude là-bas de manger en groupe. Donc quand il y a la nourriture, on dépose dans un grand plateau avec du couscous et de la sauce et on demande à tout le monde de laver les mains dans une même assiette, mais sans utiliser le savon. Pourquoi? Parce que ce n'est pas donné là-bas. Le savon est juste utilisé peut-être pour quand on se lave ou bien pour laver les habits, mais la plupart du temps quand on passe à table, on ne se lave pas les mains avec du savon dans ces communautés-là. Merci.
Thank you. Did you hear? Because from my device, I could not get the translation. Others have heard the translation, right? Okay, thank you. Then, is it Teta? Oh, please come ahead to respond to your questions.
Thank you for the questions. For the first question that was asked regarding the burden of typhoid fever in Rwanda, I cannot know figures, but yes, there's a burden of typhoid fever in Rwanda, as we also have different outbreaks that occurs, and most of them, while investigating, is due or lack of wash measures. So we have also limitation regarding laboratory sampling of typhoid suspect cases. Yes. For the second question regarding the case definition, during the interviews that were conducted, as I mentioned, that we went on site and did interviews in the community. Some of the insight of the sick person or people that were interviewed during the community were also considered, where also all the information about the water tank being cleaned the day before were collected by people in the community. Yes. For the third question, if I heard well, is the outcome of the patient. At the time of the investigation, as you have seen, the investigation has started like a month, the outbreak has started like a month before. At the time of the investigation, half of the patients, some of them were treated and already cured, but we also, there were also severe cases that were also transferred to the referral hospital, but they were all treated and there were no deaths that occurred. Only 2 severe cases had occurred in that outbreak. that happened in that village. Thank you.
Thank you very much. This brings us to the end of our session. We thank our presenters for sharing with us their great work. We can link what we have seen here with the 717 lesson which we were reminded earlier. And looking at those epic caves, I think we take some lessons on how to apply the 717, and I believe we have started assessing ourselves in terms of effectiveness of our systems and strive to bring some improvement. One of the theme component in this sub-theme is AMR, antimicrobial resistance. I think this call really for us to look at rational use of medicines, not just to administer antibiotics blindly, if we are really to contribute to this fight. To our evaluators, thank you very much. And our valuable audience, thank you for making the session lively. Before I ask for a big clap to all of ourselves, I remind ourselves again that the pickup time, the transport will be ready from 6 to take us to our respective hotels to refresh, to get ready for the cultural evening. And the dressing code, the theme is the Kenya national colors: white, black, red, green, any of the color. You don't need to have all of them. And as I have said earlier, don't feel you are out of space. If you don't have any of those, all of us are welcome to that event. Let's not miss. It will be at the plenary session, I mean at the plenary room, starting at 7 o'clock. So let's get ready and get into the vibe to move with the Kenyan cultural. I believe there will be some cultural performance. It cannot be a cultural night without cultural performance, as we'll be seeing how Kenya, they are showing to us their best performance tonight. Thank you very much. Let them give me that big clap to ourselves, and good night.